So we'd like to start this section. But before I start, I'd like to just make some comments on the first session. Just maybe one or two, three comments. In the first session, I was listening very well. We talk about data harmonizations. There is an indicator that TB program do report, and the same indicator HIV program also do report. We report that indicator on WHO Global Platform, and HIV program report that indicator on UNAIDS Global Platform. But that indicator has never been the same. That's one of the indicators that gave us EDIC, right? And the source of this data is coming from the state. So when people say they are doing data harmonizations, you wonder what are they harmonizing? So one of the things I like to suggest as a way forward, I've listened to the discussions, but I think some action points are not there. So I like to suggest that from now on, we should have a quarterly TB HIV report. It might be one page submitted from each of the states. Just one page template will be shared by the national program. We have a quarterly TB HIV report that the TB program and HIV program will sit down together and prepare and submit quarterly. Is that okay by us? Is that okay by us? I need the state to talk. Is that okay by us? Yes, it's okay. So from now on, the template will be shared, but we'll be having a quarterly TB HIV report. And then both of you sit down together and then you send the report, develop the report. Others can join. So the other issue I listened to carefully is the issue of this. One of the states mentioning the review. They need to have a review. And my comment on this will be, can we ask the HIV program at the national level, TB program at the national level, sit down together and bring out a consent and think of how should this be, right? There are opportunity. HIV program is supporting quarterly meetings at the state level. TB program is supporting quarterly meetings at the state level. So is there a way we can bring this, just pilot it, but we need to come out, sit down clearly, and maybe before the end of this year, come out with a concept on that, how that should be, and then maybe you pilot it in one or two states and see how that works. That will be my two comments I have on the first section. So from now on, we have quarterly report from the state, and then TB and HIV programs sit down together, bring out a concept of how we do a joint review. We have the resources, it's there, but how should we do it that it will work? And then we meet our objectives. So TB program and HIV program, husband and wife, do you agree? Answer now. Answer me. So those two comments, please. Thank you. So I'd like to start on this. So we've collected, thanks to TB program and HIV program, they submitted what's changed, the shift from the GC6 to GC7. So we are going to look at that shift, not all of them, maybe 2 for TB program and 2 or 3 for HIV program, right? And looking at them we are looking at what worked, what has not worked, what do we need to change, and what should we stop? These conversations, I believe, this is just the beginning of it. We are going to be using every opportunity we have, like the annual review meeting. I think we are going to have this kind of discussion also, so that we really tap into what will guide us into GC8. Having in mind that our resources envelope might reduce, right? Might reduce. So don't say increase salary or increase something. Just have in mind that the money you have might reduce. So, but how can we use that little to improve, to effectively increase our cases? So I like to start with the TB. First question on TB, then I'll go to HIV, ask the question on HIV also. And we are going to be relying on the state program manager on this. So a lot of things were changed from GC6 to GC7. One of it, next, just scroll down. One of it will be the first discussions, is TB. So when you look at community TB interventions, in GCCs, all of us are familiar with it. We have one. It was implemented under a PR that is a public sector PR. The coverage of it was 12 states, in addition to what the USG is supporting. In GCCs, we use what is called the TB Community Worker, CTW. It is performance-based. There are hotspot mappings in very few states, but not in all the states. In GCCs, go down small. And then we have some form of data harmonizations. Can you just scroll down a bit? But I still need the table. Right? Okay, so these are what we have in GCCs. But in GC7, a lot of things change. One, it's now implemented under PR for private sectors, and we have about 6 SR instead of 1 SR. So which means we have a lot of opportunities, a lot of people doing a lot of things in the GC7. The coverage from 12 states increased to 36 states plus 1. So which means all the states now are doing community TB, one form or the other, right? And then when you look at in selection of the something disappeared. So in selection of the CBOs, while we leverage on the existing CBOs that was used in GCCs, the Stop TB play leadership role in selection of some of these CBOs, additional CBOs in this GC7. So which means even in the planning, community were really, really engaged. Then now instead of having community TB worker, we have community TB HIV worker in GC7. It's still performance-based, both sides. Now we have screening tool that is used, which was not used in GC6, ComTB app. So yesterday, when you look at the Dr. Obioma's presentation, he was talking about footprint. The footprint is from Community TB app. So with this now, we can say this is where you are screening from, and we can map you. So it's easier. So which means we have a better technology in GC7. And then we have hotspot mappings, EWAS and EPCON, scale up to 36, state plus 1. And the good thing about it is that we have also been able to leverage on EPCON to map where the pregnant women are. So a lot of things have taken place in GC6 and GC7. So with this, you expect a lot of results. You expect a change. Can you go down? Before I come to questions. So we have data harmonizations in all the 774 LGA, right? So that quality data are coming from those LGA. In addition, instead of using verbal screening, which is what we did in GCCs, now we have opportunity and we are using a portable digital X-ray with AI. So which means we have a better screening tool, right? That's what we have in GC7. Go down, right? Okay. This might not show clearly, but this is what is happening, right? The GC7 started from 2024, and we have a decline in community TB cases. We had a decline. That's the rating. We have a decline about 30% in GC7. This is when we scale up to all 36 states plus 1, right? So when you look at what we did in 2024, in GC6, the last year, 2023, and what we are doing in 2024, the average, just a root calculations, the average number of cases per state in 2023 is 6,418. When you use that for 2023, it's 4,023. So which means there is a decline, right? So the yield from community is declining. We are aware of some contextual issues like messing, stockout. But when you look at diagnose and notify, the different audience does not explain that gap, right? When you look at the first year, I mean, we know it's first year of the ground, people are just starting. But when you project for 2025, the increase is not much. That's a projection for it. So we are not going to be much. We're not going to be having much. So, and we are aware of what happened in 2025. So the question is this, which means there might be some things that is working, and there might be a lot of things that is not working. And that's why the question is this. What has worked? What has not worked? What do we need to change? What do we need to do better? So I'd like to ask open the floor for the state. So you have done community team intervention in your state. What has worked? From GCC to GC7, what has not worked? The all is too quiet. What happened? Right? I want the state. I'm going to be leveraging on the state. I'm going to come to you later, and you have the opportunity to implement the state. There are states that have done state. I want the state. And I'm going to call. Do you want me to call the state? Because I know the state that are here. So what has worked? What do we need to change? Do you want us to continue the way we are? It might be the coverage. Are we spreading too thin? Are we spreading to all the local government? I mean, what is it? Yeah, state. Delta state, please. Delta. Kogi, Borno, please get ready.
Thank you very much.
Yeah.
Yes, one thing I've practically seen that has worked, I think almost every aspect has worked. But let me use the word however. The funding supporting it, backing it is grossly insufficient. Let me take, for instance, the PDX machine. It is a game changer, no doubt. But moving it into the interior as expected is not as portable as we so describe. For instance, in Delta State, we need like 3 machines to carry this, use the word portable PDX machine. Okay. Now, at the last zonal review meeting we're just coming from, there was a group that came describing a smaller version of what I will now assume or take as real portable. It can be hung as a bag with the tripod. That, for me, is portable. One person can carry it. But the present one, the funding to support, for instance, for a place now, they want to move, say, from the capital in Delta State, we take you like 5,000. By the time you're going to the interior, hard to reach, you are spending 40,000 to go in and come out. We're not talking about the riverine area. That's ×3 of this. You understand? Another thing that they've done for us that has worked is this PQA for Delta State. It has really made a lot of change for us. Apart from seeing that, okay, it's giving some fund to some persons, no. But we have used it to increase diagnosis, people put on treatment. So for me, all of this has really worked. But let me use the word again, however, the funding, if it could just be increased a little, it will really make for us a difference. Probably because of the economic downturn in the country, it has not been as it used to be, the kind of funding that backed it. Thank you.
So thank you. So you talk about riverine area, hard to reach area. How do you move those mobile support? Because I know there are resources for hard to reach area. So maybe it's not, that's what you are saying. Okay, Borno State. So what has worked in your state? What would you like to see changes?
So thank you very much. So presence of the CVOs in the community, it has worked very well in Borno State. They are almost contributing 50 to 60% in terms of our TB case finding. If we can recall last year, 2024, Borno State almost doubled, 100% increase in TB case notification and TB case finding. And most of the cases coming from these hard to reach areas and security compromised settings is coming from the CBOs, that is community. Because during the recruitment process, they involve people that are staying in this community. That means as part of security adaptation plan. So the other challenge is pertaining the PDS. I think they have been given 13 outreaches in a month. So I feel this one is inadequate. It can be often. if they can work 30 days in a month, it will help in increasing our presumptives and reduce wastage of our molecular cartridges. Thank you.
Thank you. So let's clap for Borno State. Borno State is one of the states that we're not doing community activity in GCs. So it's one of the expansion, and last year they doubled their case by 100%. Please put our hands together for Borno State. So which means the intervention is working, right? It's just that we need to rejig it. So, okay. Next, last person, Anambra State.
Thank you for the opportunity. Actually, for Anambra State, a lot of things have really worked. Like my colleague said, PDX, is a game changer. And but there are things we need to look at, like the servicing of all these machines, because before you know it, the problems will start coming, and they've already started coming. So there is need to have an in-country service points, people that will be on ground, not when something happens, you are taking it outside the country. By the time it will come back, it becomes a problem. So I think there is need to have people on ground that will be doing these services for these new machines, because it's really helping us to get to find these cases. Then another thing is trying to improve on the monies, the funds allocated for the PDX, that is for the outreaches. It's also will help a long way for the people going out there to do this work. So I think I have to stop here. Thank you.
Okay, Dr. Impero.
Space that we're doing community intervention initially, and also we continue with. Can you tell us how much you have worked with that and how the transition happened, how you were able to sustain the implementation, so that others, so that we can all know whether you had challenges and all that? Thank you.
Okay, actually, one thing we have been able to do before we go out there for our outreaches, we make sure that everybody, the stakeholders involved, because we have a platform and there must be a work plan. In fact, before you can go out, before the next month, the work plan must have been done. Everybody will be in agreement. And there will be a mail and also the WhatsApp platform that coordinates everybody. So there is always an agreement on where to go. Yes, there are times when we may need to reprioritize. Maybe something comes up, from time to time, because of the election coming up in Anambra State and a lot of things going on. You see a request being made where people gather and the rest. So we do that. But one thing for sure is that we sit down to do our work plan. The TBLSs are involved, the state team are involved, the CBOs are involved, and also the SR coordinating all these things are involved. So when they send it, we'll look at it. Are they really going to where they are going to find these cases? I've had, cause to at times to not agree with them. We make some changes, and because all we are looking out for is to get these cases. So that coordination is very key. It's very, very important for you to be able to find these cases. So we do that, in Anambra State very well. So, and that has really helped us to increase our case finding. And another thing is that because we make sure that we hold every, because there's a way we have CBOs working in the States. So there's a way we share these PDS machines actually. So you have to actually go to the field and make sure that you utilize your fund. You know, when we started initially, some of them were not meeting up. And we said, if you are not doing that, that means others will take up your fund. And based on, you know, the targets being given and the number of time the PDS is supposed to at least move in a month, you know, so we make sure they utilize their funds and also be able to get the cases. At least last quarter, we really made, you know, a number of cases from PDS. Thank you.
Thank you, Anambra State.
Thank you very much, and good morning again, everyone. I'll begin by introducing myself. When I was walking around, because we didn't do introductions, I realized some people may not know me, and I apologize for that. My name is Margaret. I work with Jean Thomas. I'm the fund manager for HIV and TB for the Global Fund. Online, we have all our colleagues, the country team members who usually support these grants. And for us, these review meetings are really, really critical. I can promise you they are listening, we are analyzing, we are trying to use this kind of critical information to make decisions that will support Nigeria. I've opted to intervene at this point because the graph that was shown, I think the next page, if you sit there and stop there, what this graph is telling us is that Global Fund should reassess whether we should invest in community TB interventions. It tells us that the critical analysis that was done in GC6 that led to the decision to support the country to expand community TB services in the entire country was flawed, because that intervention is not working, because it's not yielding results, and it's declining. Is that what we are saying in this room? How do we explain this graph in a way that allows us to live here with confidence? And even as we begin the negotiations and analysis for GC8, we are all clear on what the root causes are for this, or what the real picture is, so that we don't leave here with the wrong conclusion. I just thought for this particular one, it's important that we get the right analysis of why this is the picture, so that we don't make the wrong decisions for GC8.
Okay, can I respond to you?
I think Dr. Obioma wants to say something.
Okay.
Okay, thank you. I think the responses were just for program managers. That's why I didn't say anything. But like I said, we can't at this point compare GC6 and GC7 APA. There are key reasons. One, 2024, if you check the grant 2019-2020 and the grant 2021 to 2023, is seamless. If you check how the community had increased from 15% to 89%, because it was under the same implementation, nothing changed. The community-based organization was just the same. You know, it was just what they were asking then was, should we start work in January? Is everything the same? And immediately we were sure of what was in the budget. We just say start work. We don't need to advance fund, so just start work. So it means that it was seamless. If you get to 2023 to 2024, it wasn't the same way. There was change in implementation. Then there was initial, you know, when we are looking at this, we have to look at it with the building blocks. You don't just look at human resource. You look at consumable PSM. You look at financing. Everything would have to speak to this graph. This is just numbers. But this number of patients will not say it all for us. And that's why we have to merge all those things for us to make a decision. In 2024, I remember that there are some states that CBOs did not start till about Q2. Is it true? And with that, there were some management issues that came up, which had to be surmounted before they started. So everything they should have done that will feed into numbers in this can only be forecasted. So it means that there are numbers mean here. And also, I remember that when we got to Q3, and these CBOs are giving their stipends with patients placed on treatment, and we had so much drug shortage, and patients were waiting. Some were saying, there's no need for me to keep screening because patients are waiting. Why will I screen, get them? I'm facing them sick. We can't give them drug. And yet, I still can't get communication allowance to go to the next place. It decreased screening. So 2024 was affected by a whole lot of things. And that was why when I was pregnant, I said, in 2025, we expected a whole lot of things have been solved. We are now in cruising mode. We should move into 2025. So now in 2025, we got into 2025. When the stop work happened, everything you got between that stop work till when they resumed. I remember when they resumed, they didn't resume. They said they have resumed. It wasn't as start like this. So there was time lag. It is the community from GC7 that has supported what you've seen in 2025. And if 2025 is giving you 38% referral, it shows you the ability of GC7 to buffer 2025 community. So 2024, 2025 is not sufficient enough to judge what is happening in the community. Remember that in terms of community referral, when we got into this grant, there were agreements. Fundings are coming from this, patients are coming from this. USG has particular contribution across PPM, across community. They are all supposed to feed into this number because we are reporting a number on a national base. We are not reporting global fund. But if I tell you that to a large extent in 2025, that we have reported like 60% of global fund than USG, like 60% of the support that has happened is more like global fund. And a whole lot of, should I say retrieval was from the USG. So the way I view it, honestly, with my own analysis I have done, is that community GC7 has paid us much more than community GC6. And the analysis for community GC6 was made based on the scenario, what was available, and we didn't have stock outs, we didn't have USG stop work, and we were at that point. Now with this and everything we have seen, I think it's too early for us to judge this. And if we must judge, we have to judge in the right context, which is all these things put together. So with this few points of mine, I hope I've been able to comment.
Okay.
So I know that I wanted to speak earlier, but we wanted to hear from the states. But I strongly echo, the comments that Dr. Obioma had made. The other thing to note is that, and we have had this outcry from the communities over time, and I think that one of our review meetings, we had addressed it. One of the challenges the CBOs are also facing, many of them are dropping off. And they're saying, look, we can't cope with this anymore because it seems that it's the lead CBOs that takes it all. We don't have any office supports. We are paid based on the cases that we are identifying. And of course, when there's a stock out of treatment, we cannot be paid. So the whole arrangement is a challenge. And people are saying the foot soldiers are working. and we're not getting sufficient remuneration. The other thing that a lot of the community actors have raised is that, yes, community outreach is prioritized, but the amount of money that is allotted to community outreach is nothing to write home about. Even if you are going to ask healthcare workers to come, some of them don't want to come. You know, we've worked in Lagos State, and we had a small grant to organize a community outreach around World TB Day. And we work with Damien Foundation. They mobilized for the PDX machine to come and all of that. And the communities were able to mobilize more people because they said, oh, the money that you are giving us for this is something, you know, and people came, and a lot of people were tested. They said the money that Damien typically gives us cannot even buy biscuits, you know, for the community outreach. Sorry, sir, I'm not putting you on the spot, but you know, those are the realities on the ground. And so if we really, and I know that at some point we even had side conversations on, you know, do we reduce the number of CBOs that are working per state, you know, make them like 5 or 6, and we know that we're resourcing them, giving them the adequate office support so that they are able to, you know, do the entire work. And those are conversations that we had last year, but I think they ended up, because I know IADVN said they had done the maths and, you know, the cost was going to be very humongous. But those are things that we really need to look at if we want the community to work. Just last week or yesterday, I got a call from the FCT manager, TB manager here in Abuja, and he was saying, please, what can you do to help us get communities back to work? Because everybody is saying they don't want to do this work anymore, and the work is left to the lead CBOs. So those are the things that we need to look at, those operational issues, to really get the community back on board, you know, to help and support this process. Thank you. Okay.
Thank you very much for allowing me to speak finally. Thank you, Dr. Money. You know, when you are calling program manager, I was raising my hand because I think you should have started from we that are actually implementing. If you look at part of what I wrote down for what has worked, in fact, number 1 was more active use of community platform for TB case finding. That's what we experienced. The data is here with me. And next we will be presenting Lagos, you will see what we actually recorded. But when I saw this, I was a little bit confused, but Dr. Obioma has explained that this is actually national. So what Ms. Lydie said, actually in terms of operational, may be an issue to us implementing really when we first started. We've written to ISBN, we've had discussions, and at our own level, we try to rejiggle 1 or 2 things. But to me, in terms of what has worked for us in GC7, is the availability of more platform, especially at the community level, for TB HIV case finding. But if you want me to run through what has worked, but since we are discussing this, maybe later if I have opportunity, we have a lot of things that has worked. Though we have some things that we think we can still change. But I don't know if I have the opportunity to just run through it or I should just stop here.
Can state.
Yeah, what has worked?
On this, yeah.
On the community, no. I've mentioned what I want.
Thank you. John, JT.
Yeah, thank you. I think these are very interesting discussions. And I was really expecting this. When you started, Dr. Money, I was like eager to hear what we are discussing now. Because I was whispering here to say that why didn't you say exactly what Dr. Obioma said at the beginning now to provoke people to say exactly what they are saying now? Because they were waiting for the fact that to come from you to say, this is what we think that happened. Like this issue of giving incentive, mobilizing the community, motivating the communities. And they were waiting for you to state all this so that they now tell you what they have from their heart, as they are telling you now. So then I have 2 questions. you say, Dr. Obioma, I want to know if this is really reflecting the national picture, or is it only the global fund? Because you talked about 36 states covered by global fund resources. We know that the USG is also implementing community in 18 states. So we cannot just analyze the picture of from the global fund, ignoring that. It will be good to state that at the beginning. The second question is, now, if you state all the facts as expecting that really moving forward, Dr. Obioma, as you are stating that it's very early to analyze based on the changes. But from what we are hearing is that these are the changes that are instead impacting negatively and might continue to impact negatively. So what do we do so that we reverse that? That is one question. Secondly, what do we do to talk now about sustainability? Even if we manage to increase by end of 2025 or moving forward to 2026, how do we solve those problems in the sustainable way? Like, how do we mobilize and motivate the community in the way that we can sustain, taking into account that we may not have the luxury of the same amount of money we used to have? Then what do we do? What kind of measures do we put in place to ensure that we increase the result, but in the way we can sustain it? Thank you.
Okay, thank you. So we have about 4 questions, right? So, and we can respond to it, but I'd like to start, then I can have some other comments. So to say, this is the national data, right? Like we said, so, and here I put some context that we have stock-out medicines in 2024. It's the first year of the grants. And then we have the US policies. These are possible factors that might have impacted on this. And when you look at it, when you look at some states like Borno State, for example, take Borno State, for example, Borno State has never done community TB activity before, but you can see them increasing with community TB by 100%, right? If you go to some other states that have done it before, you see it reducing, right? So which means there are things that are working in some states, there are things that are not working in some states, right? So we should not, I mean, if you look at it umbrella and say everything is working, that might be a challenge. So that means there are things we need to really, really look at. Like you said, some of the factors they have listed, like the list CBO was saying, some of them, if they ask to stop at CTW, the rate at the CTW are dropping, because if you don't find the case, you are not paid, right? So this, I want you to come out from them, because I know some of these factors, right? I know the CBO is not paying office, they don't have an office and things like that. Do we reduce the number of the CBOs, right? And then support more of the community, something. But I want you to come out from there. That's why I started that way, right? So there are a lot of things you could do better. It's working. I mean, like I have showed, there's a lot of contextual factors. It's working, but there are a lot of things we can really, really do better, right? Looking at the coverage, is it working the same way in other states and things like that? Dr. Emperor.
Okay, thank you so much. I think we have said some key things. One of the key things we also need to discuss critically, when I look at this information, I think under presentation, it's for discussion, but under presentation, I would have looked for a trend first by quarter, And then if you look at sometimes absolute numbers, it can give you some information that are different from this increment. Because I mean, when you say percentage increment, and sometimes it may be that I am in 10 and I jump to 18. If you do that calculation, it's 80%. But I may be in 10, I may be in 20, and I jump to 10. 8 and 10 are not the same, but when I do the calculation, it's 50% increment. So some of those factors can play. Then I look at here, when you say, when somebody sees this like minus 33%, it's a spiritual attack. You get what I'm saying? Because it's key. We look at these things. These factors are not, for me, transition is always very difficult, especially when you're expanding, not just only transiting maybe from an existing state to another. It's also difficult with the state because sometimes even the CBOs, you know, we call them civil society organization, but there's a name I used to call them. They understand that one better. But that is, they can still not function. We're not sure of the finances. So within those periods, it can be very dicey. Then secondly, I think the major discussion in community is, for me, is not whether it's working. We can do analysis whether it's working the same way, the same stage, but is the implementation process is very key, and the cost. And we cannot, as national program, come up with what is efficient for you and cheaper. Because each time I see that, sincerely, I'm a very worried person. Now, I'm not withdrawing myself as not part of those who said we should try this concept. We tried it in 12 states and it showed results. But what we need to look at is it possible we look at the community, will sit down again and look at the process of implementation and come back to us and say, if we do it like this, it will be better, more efficient, we get the same results. And then it's cheaper. Very important. Because the style we are using now, whether it's sustainable, I'm not too sure. That's very critical on our own side, on the community component. Please, I will plead that the community should go back. We tried the use of payment, what you're saying, without incentive. We tried it. It was the initial side, but I mean, you can't, when there was no incentive, what we noticed was that there was no case coming from the community. The cases coming from the community was very minimal. If you take a look at our community activity before the incentive component, you find out that it's as low as almost as if community was not, everybody was struggling. It was not, the result was too poor. But we have tried these concepts. It looks as if it's working. But now the work is turning to a load. So how do we continue with the speed but reduce the load? That will be very key. It's something we may not be able to resolve now, but we need to come back to us before even the end of December and tell us that, please, if we do ABC and all that, I'm just relying on you on this critically to come back to us with that discussion. Thank you.
Thank you. And
clap now.
Okay, so before we go to the next point, please.
Thank you very much.
Thank you.
I remain Abdul Qadir Ibrahim, and it is interesting to really hear what is happening, especially from the TB community. When we started, there is a strong collaboration between NEP1, especially regarding the work of the mentor mothers, with the TB community. So at first, there were a lot of challenges because these guys, they don't show up at the community to work. And the mandate given to NEP1 that you can't go independently on your own, to work at the community, but you must work hand in hand with the TB implementers. Unfortunately, we don't understand some of the pain or constraints they were having in their own program. We were just asked to collaborate. So sometimes our people will come and they will tell us that we are out to work and these people are not available. At the beginning of the project, I went to Abakaliki. I was in the state. If we have representative in that state from the government, they will confirm. We don't even know who are the TB partners in the state. And from Abuja here, we were told implementation has commenced. And our people have to start going door to door to government offices to get test kits to go out, because mentor mothers are already trained from various project implementation from US government partners, and also they were trained on community testing. That's how we were able to gather data that were reported at the beginning of this project. Now that the issues are coming up and the linkage that we are trying to put together in terms of harmonization, there is a strong barrier between our programs and how we engage our implementers. It would be good to really look at the incentives, most especially because that's one of the key challenges, if I understand, that is really killing the morale of these people. So we need to look at what are the minimum standard that are being provided. For example, for adherence counselors, SNT that we have in the HIV. Because if you look at the way HIV has grown and the TB, there is a huge gap. And it is one of the critical challenges that we are experiencing now. Already the Global Fund has said that we should harmonize and integrate and work together. Unfortunately, some of the rate that we have, that we pay these people, is a bit higher and comfortable for the people to work within our HIV program. And now, you are now saying in the spirit of this harmonization, already you are reducing the cost we have in the HIV, and it's creating a big problem. And it is one of the issues that we also have and that has also been extended to the CLM. I don't want to go into that discussion because you have already highlighted that there will be a dialogue session for that. So I don't want to go into those details. So I want to appeal that we looked at the structure of and the cadre that we pay this community work, and it should be across board so that everybody will work comfortably, and then we'll boost their morale to work effectively at the community. Because already the TB partners, their workers are already jealous of NEP1 mentor mothers, because they said you are getting about 128,000 and we're only getting peanut. So if we want to promote and ensure that people come out and work, we need to improve them, and we should not put them only on percentage. Maybe when you go out, this is Nigeria, things are difficult. I can guarantee you bag of rice is about 60,000. And most of these women are women who are widows with plenty of children. So we need to find a way to support and standardize the rates that we pay between HIV, TB, and by extension, even the malaria component. So this is my own submission on this, and I hope it's noted and it will be able to address our challenges that are being provided. Thank you.
Thank
This
you.
is my submission.
So we need to move on. I mean, it's clear what we need to do. Like Dr. Emperor said, we need to look at. Okay, you want to say something? Okay.
Thank you very much, Abdul Kadir, and thank you for all the reflections on the community operationalization. I think I wanted to request, I don't know whether it's feasible, because we have to carry forward the conversation and we have other areas to discuss. And indeed, this is such, it's a monster with many horns. If we try to kill the monster completely now, we will not be able to. But I think where Dr. Emperor landed is probably what we should take forward as the key action on this. That we need to have an analysis on the operationalization of community activities for TB HIV. That analysis needs to be done at the state level. So you convene at the state and you analyze for your state, this is how it's working, and is it working well? And if it's not, what would you propose as a shift? As opposed to leaving that for the federal level, who will then come up with a model that is being applied blanketly across the country, and maybe it's completely not working in other places, and in some places it is. The analysis also needs to be done at the federal level. And here, I think IHVN will be key, because you can do the analysis, not just the programmatic one, which you'll get the data from NASCAP and NTB, but the financial one. You can crunch the numbers, and you can do a pairing and say, this is what it is actually costing, this is what it is yielding. At the end of the day, Global Fund is a financing institution. We finance based on return on investment. And until we can make a critical case for these interventions, we will have to move in a different direction. Incentives is something we really struggle to get approval for. We justify and explain, and it is one of the only interventions, I think there are like two, where we must get written board approval to allow a country to implement incentives. So we really usually have to explain it. And if we are saying that it's probably problematic, maybe we should be moving away from paying incentives to now paying, institutional support. If we are saying maybe the model that's working in HIV, which is extremely expensive, when the numbers will be crunched, you will see the millions of dollars that go into that. And it's important. It is important work. We are not going to even debate that. That is very important work that must continue. But we all know the global funding context. We all know that we have to do more with less. And so if we have to do more with less, we have to make sure that the little we will have is going to yield to the optimal level of results. And such kind of solutions, if you don't come up with them, unfortunately, what ends up happening at the end of the day is that at the federal level, at the national level, some decisions will be taken. If those decisions are also not feeding well into Global Fund's review, and we have also many layers of review, we will take decisions. And those decisions may not be the decisions that will actually lead to the results that the country needs. So really, it is up to you. You really have to take it in stride and recommend those solutions that you know will work for you. And you do it now, not crunch time when we are doing country dialogue, funding requests, grant making, because at that time, you've all been through it, I think, at this point. It is quick review, quick analysis, quick decisions, documents are finalized, grants are approved. Then 1 year into implementation, people are complaining about why it's not working. Yet we are at a time when we are proposing solutions. So I really want to propose that that's where we leave this particular point, that we leave it at the action is with you. You need to do your analysis, and you need to make sure that that analysis is understood, and it can therefore be defended or, to support any future decisions around community level investments. Thank you.
Thank you.
I made the comment in case if you also agree with it. So in 2024, I think the number notified, because Nigeria notifies, it will also be nice that we add the numbers or the number of those who were not placed on drugs, those 25,000, and take a proportion, community proportion, because there's community, there's facility, PPM and public. So we take a proportion and add and extend and say, okay, this notified, but this would have been. Then in 2025, we'll calculate the proportion for USG for those months that they were not there, using their attribution, because there's an attribution for USG, which we have seen a trend. We'll calculate it and say this was missed, and say it would have been this, if not USG. So that when we do that analysis, it will be like not just seeing these numbers, they can also see the other scenario. Okay, thank you.
Thank you.
Sorry, Your Excellency. Sorry. Okay. So what will happen is that I think we during the analysis, it's good that they look at, you see, because USG is in some states, but there are some states where there are no USG. What actually So because that's what I'm saying. If we do total, we may not be able, we may mask exactly. So we can look at some states that are not USG, what actually, because it gives you a clear picture of what actually has happened with the states where Global Fund is just implementing, supporting, so that we just, so that as they are making, I'm not talking to us now, I'm talking to the Olaide them, so that as you are writing your stuff, you'll be able to say, okay, look at this, because me, I'm trying to now begin to hide away from USG spiritual issues, so that we get to the real issue relating to us, because we are moving to a grant, and that's supposed decision we are going to make clearly. So if you can help them with that information, that's fine.
So
Adrian will lead for financial something. So
why you like money?
So thank you. So community is working, but we need to look at it and look at what works and look at what is not working. And then we look at what is improving, what we need to improve, right? This is just what is showing. Like interpreting of this has to be in context, you know. We should not interpret it just, we have to look at the context and things like that. I think, but we really, really need to look at what has worked, what we need to change. So thank you. Just the last one, can we scroll down for the HIV? Just pick one. Oh, that what? Oh, okay. Can we just get one person from online? Please, let's see the comment online. Okay, context matters. Okay. Okay, Dr. Obioma. Excellent perspective from Dr. Obioma. Identify platform and opportunities at the community level while drawing in and proving it. Approaches provide valuable guidance for mobilizing sustainable growth. Good. Beyond the number, community may have other important benefits, awareness creation, stigma reductions, indeed great conversations, curious to understand how integrated service delivery at the community level has improved in GC7. Okay. Thank you. I think those are the comments we have. GC7 has advanced integration compared to GC6 with more CBO delivering TB HIV services. Here, the meaning of integrations remain unsettled as yesterday. Okay. The information is that GC7 has advanced integrations compared to GC6. Okay. I think that's the last. Okay, thank you. So we just one section, only one question on HIV, and then we are round up. Maybe within 5 minutes. Scroll down. Scroll down. Scroll down. Okay. So these are HIV program shift. So we have scale up of testing services from 2,000 facilities to about 23,000 facilities. We have integration of syphilis and hepatitis into PMCCT. Can we scroll down? Okay. Integrated finance training, peer data triangulations, integrated semi-annual pipeline review, last mile distributions, spot check. Okay, integrated laboratory partners coordinations meeting, integrated MSc, DQA, and state performance and ranking. So can we just pick one of these and then talk about it? So what has worked? What has worked? What do we need to change? What do we need to do better? What do we need to retain? What do we need to drop on the HIV side? Any program manager? State? Any of these items? Can we scroll up? The scale of testing services We can just pick one, any of these items. Okay, let's go up. Do you pick number one? No, go up. Go down. Sorry. So we have men. Hello, go up. So we pick number one. Okay. Can we give him mic?
Okay, good day, everyone. My name is Osabi Koyekachuku. I work with ECUS, the partner supporting Ebonyi State. So I want to dwell on, or I want to speak with respect to point one, which is scale up of testing from 2,000 comprehensive facilities to 23,000. I think it has worked and it can be expanded on. Why do I say so? One of the challenges that was faced with this is testing all attendees or eligible attendees. Why? Because of the availability of test kits. And why is that a challenge? I know we have had the HIV self-testing kits, but many testing is done using that, but cannot be reported as HTS because of it's not the recommended first-line kits. So I think what we can do is to expedite that approval so that a lot of people, particularly pregnant women who are tested, can also count when there is paucity of the HIV determined rapid test kits. That's my suggestion. Thank you.
Thank you. Okay. Yeah.
All right, thank you very much. Good afternoon, everybody. My name is Dr. Joshua Moses, SAPC Nasarawa State. Concerning the HIV program and scale up, I think for Nasarawa State, we've done quite a number of the scale up from just the comprehensive sites to other unconventional settings. I think we have currently up to about over 900 PMTCT, in the state. And we're actually looking forward to engaging more, especially from the private sector. So that is said, on the issue of number two, integration of syphilis and hepatitis, that is also a very, very strong work that is ongoing now, because what we're trying to do is to ensure that every ANC delivery point also inculcate hepatitis into it. And fortunate for us, we've been able to not just get funds approval, but also funds release for HIV, TB, and hepatitis and malaria all this year. And that has helped us a lot because as we speak, I think we've had already engaged one of the, Abbott to help us with test kits for HIV and hepatitis. We've also engaged, I think we're currently working with CHAI to see how we can get more test kits for hepatitis to be able to, distribute to some of these facilities that we're having. This is to augment the efforts that partners are doing in the state, but we just want to see that we have plenty of gaps to, keep having these issues that we're having. So for integration, I think we're doing the much that we can. We are also going beyond testing health workers in the facilities. We're also looking at the unconventional sites like the TBAs, because quite a number of people still patronize TBAs in the state. And I think at some point we partnered with CHAI, we collaborated with CHAI to train some TBAs to be able to offer these screening at their various points of service delivery. And as soon as the screening is done and anyone is tested positive, of course, we'll link them up through the help of NEP1, that's the community mothers or the community volunteers, to facilities that will be able to take up the, further testing and treatment from there moving forward. So I think that's what we've been able to do in Nasarawa State.
Thank you. Yeah.
Go ahead.
Then after him. It's 1 minute.
Okay. So For somebody who mentioned about issues regarding reporting number of tests because the test kit is not recommended. One thing I need to tell you is that you are promoting a bad market for us. One, if you use a dual test kit, state provided, use it, but make sure that those people usually are being referred. So hospital definitely will use free qualified test kit and they will be confirmed. So please, in such scenario, record what we have at the community so that we know that our data are coming in very well. Am I communicating? So that's the synergy. And if we are saying we will not use what the state provided, we are limiting the state and we are not encouraging them to take on the ownership. So for us to promote and encourage states to do more is by acknowledging what they provide, and then we'll use other means within our program to be able to validate what has been done at the community. So for me, I am not in support of that because it's killing our market. Because me, all I want is to identify positive women and refer to to the facility so that they can have access to treatment and their babies. So please help us and document that. Thank you.
Thank you. Give it to her. NSAPC. Wara.
Thank you very much. Good afternoon, colleagues. My name is Tine Woji from Achieving Health Nigeria Initiative. So I'll join with my colleagues from ECUS when he was talking about scale up of testing services from 2,000 compared to about 2,000 to 3,000. Yes, that has really worked for us in terms of increasing the number of service delivery points, facilities to provide services to. I want to put this on the table so that we're thinking about this. So yes, we'll scale up to more comprehensive facilities. Based on the reprioritization budget, we have deprioritized payment of operational costs to facilities, which is something we're doing before. We've also deprioritized things like referral hub meetings, cluster coordination meetings, and some meetings that were happening at the facility level. And I believe that these are changes that are yet to be communicated to the state in terms of I'm talking from the IP perspective now. And normally, when you start off a project, these are some of the challenges because the facilities, we say, sign an MOU with us, tell us how you're going to support in terms of operational costs. So what we provide as support is for them to possibly maybe for a standby generator or something to provide fueling and some other minor things. Going forward, when we say to them, because we've signed an MOU with them, in that MOU, we've made a commitment to say this is what we're going to be doing to the end of the project. What it means now is that if these activities are deprioritized, we have to sign a fresh MOU with them, saying to them, these are the issues. My point, I'm coming from the point of the government having to communicate this at the lower level for a clear understanding of why this deprioritization has happened and the change in the funding landscape, or to provide an alternative is going to be a big issue. Maybe we're the only state experiencing this because I really haven't heard this from any state. But I know that when we're onboarding, starting off, this was a big challenge for them to sign the MOU. They would tell you, well, how is the project supporting? What are we bringing? So now when we go back with a new MOU, it might take a lot to get them to actually sign off. So this should not just be left for the implementing partners to deal with at the state level. The state government, even at the national level, we need to be able to communicate clearly what this deprioritization is all about. Thank you.
Thank you. Kwara State, SAPC. Last.
Thank you very much. My name is Mohammed Oyelu Rashid, Kwara State SAPC. Talking about the number one point there, the scale up has actually helped the Kwara State program in the sense that our coverage has actually improved significantly because we can actually go to almost all the local government through the scale up. However, the comprehensive site that we have in the state is still limited to 21 in 11 local government, leaving about 5 local government that doesn't have comprehensive sites. This actually is a serious gap. But what is the state doing concerning that? We are lucky to have UNICEF support for CMON activity, where we are using upgrading about one facility per local government for CMON activity. CMON is comprehensive, emergency obstetric care, where the support will come and they are going to upgrade those facilities in the state. Through this, we hope to actually use them as comprehensive sites for the state. Also, there's still more facility that is in wards in the local government. So this also, that's a patient from those wards will actually be referred to the comprehensive sites in the secondary comprehensive site in each of the local government. So this one will now make us to have good antenatal coverage. You can imagine what is happening presently, where somebody in those 5 local government that doesn't have comprehensive sites, when we now have claims from those sites that has to go to another local government, how do you expect such a woman to come and deliver in those comprehensive sites that are not in their local government? It will take a very serious challenge for them to do that. So looking at this gap, so in our hepatitis implementation, there's much of the hepatitis comprehensive site, we're still going to use that same CMON facility, which has been upgraded in each of the local government to actually expand our hepatitis coverage. Of course, when you are talking about hepatitis, it's not only hepatitis that will be taken care of at that facility. It will equally involve HIV. Thank you very much.
Thank you. Thank you. Let's put our hands for ourselves. Thank you. So the expansions has really drive changes. There are issues of reprioritization that need to be discussed to move forward. So that's good. So we end the sections. We have identified what has worked, what has not worked, what do we need to change regarding interventions in TB. And just to end sections, please, can you bring out your phone again? And there's a question we need to ask. The first one. Answer. So which from GC7 to GC6 to GC7 drove the most improvement, and what did we learn? So can we? You take over this.
All right, ladies and gentlemen, thank you very much. So we have 30 people online. All right, so it'd be great if okay, great, more people are joining up. So please join up. Online community, we hear you. We know you would like to echo your voices. So this is an opportunity. If you haven't been able to express yourself, please use this opportunity and this platform right now to express yourself. And we're going to capture everything fully. All right, so you will see the code either at the top 4800-2469, or you can just use your phone and get the QR code and already in. So we're using the same one we used yesterday. So if you're plugged in since yesterday, then fine. Beautiful, we're beginning to see some feedback. All right, so keep it coming. We want more people to sign up and then more people to contribute. So this is the time where we get to share all of our feedback in terms of what were the shifts that drove cycle 6 to 7. So if you need any help in terms of plugging in or onboarding to Mentimeter, that's fine. Just raise your hand. We have our support team that will just go around and help navigate you. So is there anybody in the house? And thank you very much. Keep it coming, keep it streaming. All right, so once we get a sizable number, then we'll run the AI, or we can just even just go through everything. All right, thank you very much. So we're hitting 20. If you can do a little bit more. Thank you. All right, great. Keep it coming. I can see some people type in textbook answers. Ouch. Is this for this session, ma? You crashed the system. All right. Thank you, sir. Oh, you are doing analysis on community. Somebody is using ChatGPT. Please don't break Mentimeter. Let it not be reported for Nigeria that Mentimeter crashed. Nice one. All right, so can we have more contributions? I know you may not be able to. Can the support team help at the back? It seems the back are having some issues in terms of Mentimeter. Let's kindly help them. And then the online community, please, let's hear you loud and clear. All right. So we'll give it a little bit more moments as we continue to contribute. I can see right now I'm hitting 40, going to 50, so that's great. And then once we hit a sizable number, then we'll just use AI to do a quick analysis of everything and we'll move on. Thank you. You can just scroll down so we can see what's down. So we can have an idea of the answer. So ladies and gentlemen, in just 5 minutes, we've been able to get almost 50 responses from the entire audience of both community online, as well as the people in this. So you can see CBOs from the community talking about increasing our service delivery points for community PMTCT. Sure. All right, so at this point in time, as you keep on giving your feedback, we're just about to group it. So we'll group and see what happens. I can see there's a lot of contribution in terms of the community. So let's see, what are the groups, what are the areas that we think drove the most improvement? So sir, over to you.
So can we look at community engagement?
All right, so let's open up community engagement.
Okay, community interventions, ACF drove the most changes. The PDS outreaches. Okay, on body CBO, more integrations between TB and HIV. Okay. Community active case findings. Scale up of PMTCT through community testings. Integration of HIV, syphilis, and hepatitis B testing. Okay. So keep it coming and then to be documented later. Okay. So can we go to the second question?
So the second question looks at, now that we've spoken a little bit about the shifts and what we think drove some of the best practices moving forward, what were the hard questions? What were the hard knocks that we experienced? What were the vulnerabilities? What were the main challenges? So you're already logged into Mentimeter. All you need to do is just type. Type, you'll see the screen of the red brick, brown brick wall representing challenges. What are your pain points? Do you have pain points as a community partner? Do you have pain points as a program? Do you have any bottlenecks or choke points? All right, Thank you. So feel free at this point in time to just elevate your voice. Say as it is. Talk from the heart. If you have data that can back it up, even better. But right now, your voice counts, and we want to hear your voice. So online community, if you're there, can the support team just drop the code for the online community just in case they may have missed it? Let's just drop the code there. I really want to hear from the online community. We have quite a sizable number that continued from yesterday, and thanks to the thumbs up, we hear you, we see you. All right, thank you. I see some people are still typing. Some people are going into the data bank, unlocking a data bank. Great. So we'll keep on typing away. Feel free to, if you have more than one challenge, that's fine. Drop that to 2, 3, 4, 5. It doesn't matter the size. We're good. All right, interesting conversations going on here. Love the energy. Thank you. So by the time we hit 50, I think once we hit 50, if that's okay with you, sir, we can run it. So just 3 more responses. Anyone in the online community or anyone here? All right, almost there. And then we just do a quick run of the analysis and then we can touch and see exactly what's going on. So ladies and gentlemen, kindly note that because we're using this Mentimeter, we're capturing everybody's voices. So we're actually doing a back analysis of all the audience responses. We're putting them into categories, we're weighting those categories, and you're going to see that reflected in the final outcome later on. So even if we don't touch it in the group, we are not neglecting it. All right, I think so. Can we group it?
Yeah, please.
Please do so. Okay, so you can see it's weighted. The number 1 pain point we seem to be experiencing. So sir, over to you.
So can we see supply? So we have supply of test kits, need to be addressed, logistics, consumables, stock out of lab commodities to test TB patients. Okay. I think it's good. Third, can we go to the third question, the last question?
All right, so we have one final question. We've spoken about the best practices from 6 to 7. We've also spoken about the challenges. Right now, we want to ask, what are the innovations across states that we should standardize? What do we need to refine? What do we need to expand? What do we need to replicate? And what do we need to scale? Okay. Sir? All right, great. So, ladies and gentlemen, these are the innovations that should be standardized across each of our states. And I really like what's coming out: joint data review, community interventions. Can we take away the QR code? Is blocking some of the responses. Thank you. Bauchi State's signature integration of services. Can we scroll down a little? I'm seeing community leadership, community engagements. Again, joint stakeholder planning and review meetings. So this is good stuff. Keep it coming.
Dashboard. What's it? 50? Is it 50 already?
Online community. Leadership and governance. Again, this joint data review is coming up at both the state and local government levels. So that seems to be an area that resonates with everybody in this room, online community, and the representatives of the Nigeria HIV and TB program. Getting the data right from the start. Joint data harmonization. I won't be surprised if that's the biggest innovation that should be standardized across all states. So we're capturing all of this, not just in the Mentimeter, it's going to be captured and reflected on all the things in terms of the action points for this joint review meeting for the past 2 days. So we're almost hitting the 50 mark. Once we hit the 50 mark, we do as we usually do, we'll run the AI and the AI will tell us what are the blocks of change. So online community, feel free to continue to share. So if you haven't already, please like, share, subscribe.
Once it's 50, and
absolutely, sir. Okay, thank you. Somebody's liking. All right, so we're going to run it now. And then we'll see exactly what are the innovations to scale. Mind blown. Okay. Sir, over to you.
So a lot of people is talking about data harmonization.
I guess that's much.
So can we see that?
Yes, sir. We'll
Data. Okay. So a lot of things about data harmonizations as a kind of innovation that we need to move forward. So a lot of people is supporting this. Joint data review, as we discussed in the first section. So a lot of people are supporting this. TB HIV data review meetings, joint data review analysis, joint data review at LJ level, periodic joint data review. Right. So I think this is the last. Okay. So I think this is the last section. So you can keep it coming because it will be analyzed later. So we have been able to identify what has worked. We have been able to identify what are some of the challenges, and then we are able to identify some of the innovations that we need to move it forward. So all this will be analyzed later, and then it will be used, and I believe it will guide our discussions as we move forward. So thank you for listening, and thank you for your contributions. I'd like to hand over this section.
Thank you so much. A round of applause for Dr. Moniyi. A round of applause for him. Please, can we agreed earlier on that we stop at 1, some said 3. And we are also aware that we need to go and pray. I need to go and pray. I know that we usually go at 1 or at 2. So what are we agreeing? What time do you think we should go? 1:30. 2. 2 is far. 1:45 is already 1 after 1. No, because we still have a session, and that session is supposed to be for 1 hour. But I want to shorten it. And if I shorten it, we might not be able to leave here until, even at that, we'll leave here at maybe 1:45. So but I know that is important. We go and pray. You will lose it. What do we do? Before 2 o'clock. So what time do you want us to go? I really need, because we need to agree. We can't finish at 1:30. So what it means is that we start, then you go and pray, then we come back. Is that agreeable? Okay. So please, can we stand up? We've been sitting for so long. Can we stand up? Madam. Can we stand up? Stretch, turn to your neighbor. We are all healthcare workers. The people at the back, they can't even move. No award. People that are not moving. Ooh. Ooh. Ooh.
Hello. Sorry, we're actually giving we're doing giveaways to everyone who dances very well. So give us your best moves. I will choose who is doing a good job.
You are not dancing.
I am here to choose. So
It's Friday. Okay, thank you. Let's give ourselves a round of applause. A round of applause. Thank you. So please, aside the fact that we'll be using the Mentimeter, please, we want you to pay close attention. A lot of us were sleeping, a lot of us were dozing. Let's not mention names, but we could actually see those that were dozing. Please, no dozing. My facilitation, I'll be facilitating from this middle. And you know, as usual, I have my ball. And when the ball comes to you, you have to answer. The only other thing you can do is either you call a friend or 50-50. Do we all agree? Okay, so now we are at that point. We've all been talking about integration. I'm happy Dr. Money is sessioned. When you listed what the challenges are and what the solutions are, we all did agree that we had some points that we actually need to start working on. And this session is actually the session that would actually be having decision. We are making decisions. And when we leave here, even if it's 3, 4, 5 points, this will be some of the decisions that we'll carry forward. We make those decisions, we think of how best to plan around them, and then we take it forward. Do we all agree? We've danced though. You know, we have energy now. So please, can we all go to our Mentimeter? But while we're actually trying to sort our Mentimeter, I think our Oga talked yesterday and said, we all need to agree on a definition of integration. So I'll hand over the phone to him now and tell us in a word, what does integration means to him? Over to you, sir. What does integration mean? You can call a friend. You can do 50-50.
This is the ball.
Football.
So if you want to pass it, you can pass it, sir.
Yes, integration means it's at a lot of levels, about 4 levels. You have program integration, you have system integration, you have leadership and coordination integration. So we now need to start breaking it down and apply it to the context or the reason why we're here. The 3 diseases, ATM, right? And yesterday we started with the issue of integration. We're saying that if there is institutional integration at the national level, it will affect the states, it will affect the services, it will affect the service delivery points, and it will affect also the clients that are receiving the services. So I'm just going to talk about the issue of institutional integration. Before now, there was a time the National Agency for the Control of AIDS was in charge of this one coordinating body, one strategic plan, one MI system. And for me, things worked at that particular point. At that particular point, NACA was able to disburse to other line ministries at the state level too. SACAs were able to disburse to line ministries. And we had a lot of beautiful results. And now with the Global Fund coming and different sources of funding at different structures at the subnational level is affecting leadership and governance. We need to streamline the funding coming in. It's affecting leadership and governance because now someone mentioned something yesterday. We are moving towards sustainability. We're talking about country ownership. And a body started the process, involved all the stakeholders. We were called, we agreed on a plan. And suddenly, another MDA started another plan, an agenda of sustainability. So where are we going with that? So unless they get it right at the top level, we're not going anywhere because they're passing different information to subnational level. Thank you.
Thank you so much, sir. It was as if we were together when we developed the question. So please, can you help us read that? And then we all answer. Please, let's go to our, read it out. And then those of us that are not reading, let's use our Mentimeter to actually do the work. Thank you.
Okay.
Go ahead, Anambra.
What governance challenges exist in integrating HIV, TB, and malaria programs?
Please, the answers are on your Mentimeter. Please, can we respond? Thank you so much. Can you give it to a friend? Can you give the microphone to a friend? Chief over here has told us that we have institutional challenges, and that has to do with leadership and governance. Now is the time for us to actually click in there. What do you think are the issues? Please, how many? Do we have up to 50 now? Anambra, please, can you give a friend? I know you didn't come alone. Give a friend, not a SACA friend. Integration involves working with other people, not a SACA friend. Give the mic to a friend. Give the mic to a friend. Anambra, you didn't come alone, no. Now only you waka come. Okay. Please, can you come because you actually help us to read these things out?
Integration. Oh, sorry.
We have to leave here 1:45, right?
I'm here.
Okay, please, can you read out what the answers are? Thank you.
Okay, we have
Percentage and
fragmented program ownership accounting for 22%, and lack of clear policy direction for integration accounting for 52%, which is the largest. Then resistance to change from program manager accounting for 10%. Then limited coordination mechanisms at subnational levels accounting for 16%.
Okay.
And none of the above had 0%, which is none.
thank you so much. So which one do you think that we should do?
So from the data we have here, lack of clear policy direction for integration is got the largest vote. And I think it's similar to what Dr. Emperor had said, that we need to define what integration means. So I think it fits into that.
Thank you so much. Please help us note this. We'll still get to that when we decide and say this is what we want to do to ensure it happens. Thank you. A round of applause for him as he sits. Second question, please.
Throw the ball to somebody.
Maybe you have a friend. Give a friend, give a friend. Second question. Where is your friend? Oh, yeah, give her now. Please, can you read out the second question? While we are voting, please, let's continue to vote while she's reading it out.
Okay. How can leadership at different levels support successful integration?
Let's vote, let's vote. Thank you. You forgot to mention your name and your... Yes, please go on.
My name is Chidima. I work for Catholic Caritas Foundation.
Okay, thank you. Give another friend or 50-50. Please, let's vote. Let's vote, let's vote, let's vote. We are working against time. Let's vote. Let's vote, let's vote, let's vote. When is the next election in Nigeria, self? Let's practice. Maybe we use Mentimeter for that one. Eh? There will be glitch.
It will be at.
Want us to vote?
Okay, let's vote, let's vote. How many do we have now? Please give your friend and then she can come out to read it, or E. Okay, we have 42% advocacy for policy harmonization. So that is really coming out strong. Shared accountability framework. Shared accountability framework means a framework that guides our integration. Do we have that? We don't. So who wants to speak to that? Where's the ball? Where's the ball? Okay. Oh, okay. You have the ball. Okay, so we have 40% advocacy for policy harmonization. So it's really coming out strongly. 25% for shared accountability framework, 10% for established joint steering committee, 25% for inter-program collaboration, 0% for none of the above. Okay, let's go to the next question, please. Please, Mentimeter, can you help us such that people can still respond, or they have to clear before they move to the next? That's it. Oh, okay. Please, okay, let them respond to that one. Or should we move to the next? It's for us to decide, actually. Okay. So, yes. So, Madam, please, can you read this? Have we read this? This is the second one. Please, can you move to the next one? Then she reads. Oh yeah. Madam.
The question?
As she's reading, please be voting.
Okay.
Please
What
be
financing
voting.
models could best support integrated service delivery?
Please be voting. Please, the family of the groom at this side, where are you? TB folks on this side. Ah, people are not talking again. Eh? Only you. All the people here.
Mm-mm. You are frowning. I'll call you. Take. Which program are you from? You just squeeze your face. Please come and help us reach. Thank you, sir.
Okay.
Have you voted?
Yes.
Okay. You can also read it from your phone if that's
Okay.
okay.
What
But let
financing?
them see you now. Go to the front. Let them see you. Thank you, sir.
Okay. What financing model could best support integrated service delivery? So,
Speak up. Speak up.
full funding mechanism, 3%, performance-based financing across disease areas, 23%, joint domestic resource mobilization, 28%.
Thank you so much. You didn't know your name. Introduce yourself.
Okay, I'm Butano Kaduna Saka.
Saka, Kaduna.
Okay, somehow blind. Joint integration international health insurance scheme, 18%, then none of the above, 0%.
Thank you, sir. How many do we have, Maximeter? 65. So can we move? Okay. Please, can you give your friend? I know you didn't come alone. Look this side. All of them, they're not engaged them. Thank you.
Okay.
No, how many that presented? Go towards that side now. He's been active, oh. He's been active since morning. Help me give that Oga. That Oga.
Okay.
Yes. Thank you, sir. Please introduce yourself and help us read this next question. Please, as he's reading, please be voting.
Yes, good afternoon, everyone. My name is Zamdai Wafari Lassa. Yes, working for LTR Borno State. How can we ensure sustainability amidst declining donor support? That is the question.
No. Okay. No, until the answer now. Then you also help us to read the response.
Okay.
Yeah. Can you see from there? Or you want to come here, sir. Thank you, sir. Increase budget allocation. It's even good.
Yes.
Oh yeah, read it up.
So increase government budget allocation.
How many percent?
That is 73%. And 21% also went for leverage private sector partnership. And 0% for strengthening community-based financing. Okay. Then there is 7% for advocate for multi-disease investment cases. Then none of the above, 5%.
Please, if you vote none of the above, please, can you raise your hand? Please, if you vote none of the above, raise your hand. Please, can we give him a phone?
Okay.
Yes, you can, please. It's not allowing. Oh, okay. Oh, okay.
So the problem is not with them.
No, he said he didn't do any. So that's, yes. Please, on your table, you have sheets of paper. If anything you can't do here, you can actually help us to write it down, right? Put your name or where you're coming from. Yeah, and help us to, you can say question, 1 question, 2 question, that you just point it out. So that would help them in collating. Please, I'm mindful of time. I know we agreed to leave here so that we can go for prayers. What time did we agree? 1:30. So we go and come back, right?
5 minutes.
Okay. So what can we do in 5 minutes? Give your friend. Okay. Please help us respond. So you have the ball. You are not going for prayers, Abby. Yeah.
What am I responding to?
You said you choose none of the above.
Yes.
Why is it that none of this that's been written, you know?
Well, if there were option for multiple choice, I would have said, okay, more than one.
Please
But
stop the mic.
the moment, none of the above, because increased government allocation, it doesn't work, it doesn't solve anything. They can give you 1 billion in your budget, but if nothing is released, nothing is done. So leverage on private sector alone will not help, will not go a long way in doing that, because not all states have the private sector that are boosting or booming. Next, the strengthening community-based financing. Well, these are state dependent and not, it doesn't cut across all states. And we're looking at, having a standard stuff working across the states. Otherwise, there will be loopholes in some states. And also for the fact that advocating for multiple disease investment cases. Well, again, it's about the interests of one, the state, the government, and also those who are driving these various disease entities to put their heads together and see how this can actually work under one roof. So that's why I chose none of the above in this case. Thank you.
Thank you so much. Thank you. Earlier on, we mentioned the fact that there could be joint. Please let him hold the mic. There could be joint coordination. If there's joint coordination and they all agreed to the same policy and all that, do you think that would help you to change your mind? So earlier on, we did respond. The first question is about leadership and governance, and one of the options was that there should be joint coordination and all, right? If that is established, and if there is a policy that is giving the direction and all that, do you think, if that is on ground, do you think it's going to change this, your opinion?
Well, not so much. Not so much. And I'll still tell you the truth. You can have all the joint coordination. And if for instance, we have a government that is not prioritizing some of these cases that we're looking at, that we are talking about, the joint coordination will not amount to much, because you still need the resources to, finance, most of this coordination we're talking about. Few states are doing the much that they can do, but it's not all states that are keying into this that we're talking about. There's coordination in some states, but what are they getting to ensure that this coordination is properly, being put into effect? That is where the challenge is. So it can answer some questions, or it can go some ways, but it may not go all the way for me.
Okay.
Thank you very much.
You forgot to introduce yourself.
Dr. Joshua Moses, SAPC Nasarawa State.
Nasarawa State.
Thank you.
Thank you so much. There are two persons, you or him, because we need to leave now. So
statement. I think I also picked none, and the reason is clear. I didn't see insurance, which is the most sustainable, and it should have been part of the options that I expect persons to click on. So I chose.
What we need to be putting at the back of our mind, what I will call our attentions as managers, to know that it is the responsibility of the government to take care of the health of its citizens. It is a fundamental human right of an individual to have access to health care. Therefore, if you are talking of sustainability, do you expect somebody, expatriate, to come and sustain your health? No. But if the attention of government is drawn, and if the government decided to commit itself to the health care of the people, I'm telling you that will be the best way that we can sustain our activity, and even to help others from other countries. So solely I'm with government commitment in maintaining sustainability. Thank you very much.
thank you so much. Please, let's give ourselves a round of applause. It's 1:30 already, and we committed to leave at 1:30. We should be back here. When do you think we should be back?
Quarter past 2.
2:15. I can't know. Why 3?
No.
We need to go and eat now, then we'll come back by 3.
Eh?
We eat and come back by 3.
When are you
Don't
going to
go
come back from prayers?
We should be back by 2:15.
2:15.
Yes.
Then you eat and all that. So while so some of us will go ahead. Oh yeah. To go. Oh, that's please can you ask them? Lunch. Lunch is by 2. Okay, let's go on time. For those of us that are to pray, please, do we have a bus that can take them? Is it possible? Or we have vehicles? They're asking. Or there's a vehicle here that none. Okay, I wanted to say, Benjamin, are you not going to pray? Then I remember that your own. Okay. So the rest of us that are not going to pray, should we go to lunch? It's too early. What time do you want to go to lunch? No, so we wait for them. No. You don't want to eat yet. Okay. They said they don't want to go at 2. Okay, so that's it. So what? Oga, Dr. Karim. Dr. Karim. Are you not going to pray? Go now. Alaja. Oh yeah, go. Please go and pray so that and pray for Nigeria. Pray for your Jerusalem. Hold on. Don't worry. Don't worry. A prayer point, yes. Please, are you also going to pray? No, we are. Chief, no. Those of us that are not going to pray, please, let's stay back. You know that they've contributed. Oga, don't go. You know, they've contributed to those things that we discussed earlier, but we were really in a hurry because of time. Now that we are waiting, that gives us the opportunity to actually go in depth, discuss those things. They are not going to miss in that regards because this discussion, I'm sure that it has happened several times, So that's just what we are going to do. In between, we would also stretch our legs, and also it's not just sitting. Do we all agree? Okay. So, Madam, you raised your hand the other time. Do you remember the points you wanted to? You can take us back. Let me go to the questions, the domain that we've treated. Before they left, hold on, please.
Related to a domain.
Okay.
It was really about the discussion about the definition of integration. And for me, well, yes, people have talked about various types of integration. I think it's also important that we're looking at integration from a patient-centered perspective. So a patient or an individual has HIV, they have TB, and they have malaria. What is that client's expectation in terms of quality of care? How do they expect that they will be addressed? For instance, I go to seek care in a health facility. I would expect, for convenience sake, that everything I need is at my disposal, right? So I can access testing for HIV, I can access testing for TB, testing for malaria at the same place. If one partner is saying, I'm offering it free for you, then I'm expecting that all partners will offer those services free for me as well. So it's not that it's free for HIV, but for malaria, I need to pay, or for TB, I need to pay. The other thing that we also need to be looking at, and yesterday when we projected, I think part of the feedback from the Mentimeter exercise, we saw that integration came out strongly, but innovation was also a key point. And my point is that can we also be thinking innovation as we think integration? There's been a lot of conversation about multiplex testing. So can we have tests, that can test for HIV, can test for malaria, test for TB all at once so that I don't have to go from one place to the other? Again, when you're thinking from a client's perspective, we're thinking of all of these outreaches that we do. I would be more happy to come to an outreach where all of those tests is being offered, all of the information that I need to know about HIV, about TB, about malaria is being offered. Also, if I'm looking at, for instance, the kind of quality of care that I'm getting, if HIV positive, I probably have an adherent supporter. If I'm on TB treatment, I also have an adherent supporter. Am I going to have two different adherent supporters? Can I have one adherent supporter who has information about TB, about my TB medication, and who also has information about my HIV medication and can provide quality support to me? So even as we're thinking service integration, my point is we need to look at it from the patient's perspective as well. What will the patient want? What will add value to the patient? What will ensure that the patient comes out much better, either cured or treated, or is able to stay on treatment and adhere to treatment?
Thank you. Please still hold the mic, because I have a couple of questions. From a client's perspective, you want to go to that health facility and then you want to be screened for HIV, syphilis, hepatitis, malaria, and in all the same malaria, must the provide? That we also actually
offer. I'm tested for HIV, I'm tested for TB.
No, we don't have one house. Do we have one house? Do we have one house? Should we continue or we wait for our brothers that have gone to pray?
Okay, let me just say.
So you want to use 1 hour just to do nothing? Our guy said we are doing well, so we follow the leader. Oh yeah, chairman.
All right, so from the last speaker, I think the Nigerian government have tried to look into this situation. There is a program that was run in many states. I stand to be corrected. The front health workers training. It was a holistic package. So maybe it needs to be improved on so that in everything that she was talking about, every health worker was given opportunity to be trained to deliver this quality service, multi-disease kind of services. So all they need to do is to work on those documents and bring this point home. I think you can now, if it is done perfectly well, a health worker can provide all these services in one spot in the facility where the person comes. That's why I say we are doing some things, but the real impact will after some time. What we need to do is this agreement we are having is to deepen it and let us disconnect our mind from the old ways of doing things. And like we say here this morning, if TB person is doing program now, and they head from Abuja to the TB, malaria, say, this category of people at the state level in your activity. The people at the state cannot say they are not doing it. They will do inclusiveness, and then we'll move to the local government and bring them together and mentor. Even though the human resource problem is an issue, that is where the integration we are discussing will now loud it and say, the reason is this. When people come into your health facility and they don't get what they want, what is the next thing? They tag your facility that if you go there, nothing is happening. So, but when we build your capacity and you provide these various services in one spot, it will also increase it will kind of loud the image of that facility. These are things that are happening. You know, in a typical village or typical community, they'll say that hospital, if you go there, you don't see anything. No. Already they are blacklisted that facility. So with what the Nigerian government has started with that frontline health workers training capacity building, if they invest a little again, we will move to another level, and then under 1 or 2 years, I think we should be having a better outcome of what we have started. That is my contribution.
Pass to the chairman to chairman.
Okay. Let me just react to what my sister said. When you're looking at integration at service delivery point, I think I had a discussion with someone today. I said, when you're talking about malaria, everybody here, you can prescribe malaria. It is because after 3 days, when you don't get well, that's when you start looking for a qualified medical personnel, true or false. But for TB and HIV, the drugs are not on the shelf because it is what? Provided free, isn't it? HIV is even not on the shelf. So that means at that level, there are a lot of innovations that you need to do. That means you need to train all the health workers. The resources are not there. Then another thing that we can do is to mainstream all those things into curriculum of medical schools and all that. So that by the time they are coming out, they become what to be able to treat TB very well, treat HIV very well. But the treatment is, especially for TB, I think is constantly changing. Also for HIV, there are also procedures that are constantly changing. That means you need to continue to do what? Train and retrain. And human resource is also a challenge. People move, Japa syndrome. So the person that has come for training, like my friend now, is becoming a permanent secretary. Everything is except they put it in Ministry of Health or somewhere, it's going to take everything away. So that's the way it is. So it's difficult when you now talk about integration. You need to factor some of those impediments, obstacles to it. It's not, there are diseases that, let me call them maybe special diseases. It's not like malaria that everybody can sit down and just say, and just write, what's the commonest anti-malaria drug now? Antimetal, yeah, and lumefantrine. That's it. This one needs, most of the time, you need monitoring, you need constant monitoring. So at times, those are the things that you need to factor into it. So unless we can, the enough resources, which is never going to be enough, to continue to do what? And build capacity on a yearly basis for that integration at that level. You still need to refer to the program. Thank you.
Thank you, sir. Please, let's call the online family members. We have online people. Please, can you give the mic to... Okay, a lady has not spoken. Which, are you from the States or you are a partner? Please, can we give the States priority? Yes. Please, can we have the online family? Hello, people. They are not there. Abi, they've gone to pray. Please, how can we know? Hello, people. Online family. Online family, we've come to you. They are not there. Please, can you do thumbs up if you are still online? They've left. Oga Lawal, okay. No, it's only support. That's from support now. Anedi. Please, if you're online, please, can you do thumbs up? We only have from few people. Onyeka. Tina, you're also here. You're online again. Oga Bulus. Okay, do we have any comments, contributions from the discussion from online people? Please let us know. Fumi Oladipo. Fumi, do you want to contribute anything at this point? Please, online, can you put on your cameras? Maybe that would help. Please, can you put on your cameras? Okay, they are taking notes. Please, are you able to put on your cameras? Okay, we've tried for online people. Can we give
We can hear you, doctor. We can hear you very well. Oh. I can hear you, and I'm doing thumbs up for you.
Thank you. Do you have any contributions to what's going on?
Oh,
James.
We follow you.
Okay.
Yeah, thanks.
Okay. Please help us take their pictures. Those that have their camera on. Photographer, please help us to. So we know those who will give gifts. Before encore. Oga James from Global Fund, do you have anything to contribute? You've been following? Do you want to say anything to us? Thank you.
Yeah, we have been following. I'm seated next to Nebriti, and we have been following. One element that what really struck me is the people who selected the NAN, and the reason they are giving is that the donors and the government should try to harmonize before the integration can take place. That's what I think that took us our mind, and then the gentleman who mentioned that it is a right that the government needs to provide all the resources. So the funders are just helping, giving a hand. I think that's a critical point that we really need to look through. And there are other discussions that we forward through. Let's see if those can be put in the context and how we can move forward. Nobody, anything from your side? Okay, nobody says nothing from his side.
Let's see your face, Nebriti. We miss you. Let's see your face. Thank you so much, James. Nebriti. Okay. Anedi. Anedi, don't go ahead. Nebriti. Let's see your face and hear your voice exactly. It's frozen. Nebriti, are you talking? You are muted. He's unmuted. We can't hear him. We can't hear him.
You can hear me now? Okay.
Yes.
Excellent. Just to say good afternoon, everyone. I'm really excited to hear about the integration agenda coming out very strongly. I'm really so excited to hear this. So we'll continue the conversation maybe next week also when we are there.
Thank you.
Yeah,
Thank you.
Thank
See you
so much.
soon. Yeah.
Thank you.
Nicholas, are you with us? Please introduce yourself. Let's hear your voice. Then Anegdi will speak. We've said a lot. Is there something you want to contribute to the discussion that's been ongoing in the room?
I followed the conversation. Good afternoon, everyone. I'd confirm if you can hear me.
Loud and clear.
Okay, so thank you so much, and I'm following the conversation. For now, I do not have any comment. I think it's fine. Thank you.
Thank you. Anedi?
Yes, thank you very much, and good afternoon, everyone. It's exciting to hear what has worked and to hear solutions to what is not really working very well. For me, my thought would be around reimagining, or should I say, reorganizing the entire health system in such a way that it is defined how the primary health system, the secondary facilities, and the tertiary and specialist facilities are going to what responsibilities, what level of service is going to be provided, and what are the referral pathways. Because I think if we talk about that, then we can ask ourselves a larger question of organizing and funding the various levels of the facilities from the primary health center. We need to ask that hard questions. Are they getting enough fund? Are the funds that are allocated to the primary health centers given to the primary health centers, and the services that are supposed to be provided, because they are the ones that are closer to the people, are the people accessing those services at the primary health centers? And then what is the referral pathway? When we can do that, I think integration will be easy, because we can know where to plan, okay, at which level can malaria, TB, HIV services, if we are looking at triple elimination, hepatitis, at which level of each of these health facilities can they be provided service? And if it is not going to be close enough to the people, can we move service provision to the levels? I think it will set the structure and the tone for the integration. Thank you, Anova.
Thank you so much. Please, let's give the online community a round of applause. They've tried. They've stayed online. No tea break, no lunch, nothing. Please, let's give them a round of applause again. Thank you so much. Please stay with us. We're not going to finish late today, so we'll close early today. Please, can you give the mic to Oga over there? Okay. And once you finish, my lady that wanted to speak, and then we go for 15 minutes break. Yes. The folks are expected back by 2:15, so we close at 2, go for just stretch our legs and all back. Then we promise to be back here by 2:15. Do we all agree? Great. Over.
Thank you very much. My name is Zamdai again, or Farilasa from Borno State. I'm working with the partner, LTR. I want to contribute to the discussion on the integration. And what I want to contribute is that the integration can be successful, but we have to also be very careful on the level of the service delivery, because we know we also have community component where maybe this mentor model and the CTWs are the ones going house to house. Okay, in this setup, you know, we don't have malaria, we don't have TB test there, but though they can collect samples, all this can happen in the community. But in a facility, just like what the KB PM mentioned in the morning, we need to maybe classify facilities. Which facility have drug clinic, it has gene expert, it has ART services, in this kind of facilities, we need to groups or classification so that functional and service integration can fully take place in such institutions. There are some facilities where you notice the dot facility is here, Gene Expert is in the extreme corner, and the ART is in another corner. In this, in the process of promoting integration, I think we need services, a close environment in that facility where a patient can just trek from here to the other units and get comprehensive sites. So at the planning stage, we need to classify how many facilities per area that have this Gene Expert, ART, and TB services, so that this integration can be in these facilities and we can monitor their functionality. But for those in the community, maybe we'll devise a means of referral pathway also to those facilities so that the patients can have those services at minimal cost. Thank you.
Thank you so much. What I hear you say is that there's a need for referral pathway. That is lacking. Is that lacking? From community to the health facilities and from health facilities to the community.
Elaborate on the patient-centered approach. And what she mentioned, one of her points, was that a patient is supposed not to suffer. Services are supposed to be offered in the same place. But for those that are instead in the community, maybe for plasticity and TB samples collected in the community, whenever they become positive, referral must take place to the nearest either DOT facility or ART. So what I'm saying is we need to classify those facilities that have those equipments in the same facility so that functional and service integration can fully take place in those places, while we emphasize and improve on the referral pathway.
Thank you so much. Let's give ourselves a round of applause. It's 2 minutes to 2. So please, we expect our folks back by 2:15, and we've all agreed that we use this 15 minutes to stretch our legs, to use the bathroom if necessary, to make that phone call. A lot of us were actually just typing, and not focusing. So let's use this 15 minutes to do that so that when we are back, we will be concentrating on what we are to do. Thank you very much. Thank you. Are you clapping me? Clap. With that, agreement is agreement. Abi, agreement. Ah. Please don't make up your mouth. Thank you. Okay, so just to bring us back in, I'd like one or two of us to actually give us, those things that we discussed before we went for prayers. Madam from Oshun, how are you, ma? Mrs. Adeleke, welcome. Is your own Sheruba one or which one? All of them join. Okay. So please just, welcome back. 2:25. We are 10 minutes behind. We agreed now to 2:15. And our people refuse to come back in. Please, let's come back in. Oh, chairman, please, can you help us call the other chairman? So, Madam Adeleke, you've been here all along, and I know you've been active. There are a few things that we discussed before we went for prayers. Would you help us just recap one or two, those things that you think actually is striking for you? Yeah, thank you. And when you finish, you pass it to a friend of yours, just a friend. Yeah, thank you.
Thank you very much. I will say the one that interests me more, I will talk about this one. One, the marriage, the forced marriage integration. So, and we look at modalities. How are we going to make it work? So we are talking about now that the money from our donors are fading out. How do we cope? So we look at different methods. Many people, we have majority accepting that government, is time for the state government, the state government to take ownership of their people. It's their duty. There is some argument. Some people believe, no, we should have a community based support and different. But so me, I'm of the opinion that the government must take ownership of the health of their people. We are paying tax. They're collecting our money. Where is our money going to? So it's time to show for it. Actually, they're supposed to be there before, but they have been going away. They're denying, not doing their duty. So it's time now to do their duty. So that's number one. And the other one again.
Let me stop you on that one.
Okay.
You are SAPC Osun.
No, I'm the
SACA?
SASCAP, State Laboratory Focal Person.
State Laboratory Focal
Focal
Person.
Person.
So you are
SASCAP.
representing this SASCAP.
Yes.
You are representing your SAPC.
Yes, for some SASCAP.
Okay.
SASCAP.
So you are a decision maker in Osun.
Yes.
So I hear you say the government. So now as the government, because you are the government.
Yes.
What will you do?
We have written, we have written a letter. The commissioner is aware, the PS, permanent secretary, the commissioner, we have written to the government, we have written to the governor, and we are still following it up. For them, since they need to do financing, they have to take up the financing. And I'm sure our governor is a listening governor, he's the governor of the people. I'm sure he's going to do something soon. We are sure, I'm sure.
Please, note it down for Osun. Osun is one of those states where we expect to get additional resources from the governor. Please, we need to follow that up.
Yes.
I like that commitment. Please, can you give it to your friend? Ekiti can be your friend, though.
Okay.
Give it to another person. You can go this way.
Okay. Let me just look at faces. I would just love to give it to. No, I see a face I want to. Let me be a woman.
I'm a national staff.
Let me look at another smiling face from a lady. I'm not biased, but I just like women for.
There's one fine woman here, or you is man you want. Oh yeah, go to man, go to man.
I'm looking for a woman actually.
Okay.
Okay, now the
Please
women.
introduce yourself.
Good afternoon, Dr. Lako Kebu, Abia Saka DG. The women have the floor now. All right, so based on what she was discussing last, in my state, Abia State, my state government commits 15% of her budget to healthcare. So since the administration of our present government, we have enjoyed, it's not just budget on paper, down to release. So some of the issues like testing kits, all that are things that we're already taking ownership of.
Abia is already doing a lot.
Yes.
How many test kits did you procure in the last 6 months?
Right now, I have an approval to buy test kits to the tune of 90 million, like 225.
Please, help us give a round of applause. Out there, the whole world has heard.
Yes.
You have 90 million for
test kits and then the consumables that go with it.
Okay. Between now and
Abia.
Abia. Osun want to now join Abia. How now? How come? Your husband is not Abia. You that you are less on me. See what money cannot do. Does not exist.
And then our edit just moved us under the supervision of Ministry of Health. So it's a lot, initially we thought it was going to be problematic, but it's a lot easier. Our memos move from the commissioner to the governor and we get approval.
Oh, yes. Okay.
Then we've done a trend analysis. So we've kept government informed of the implications of all the Trumpers and all that. So everybody's gearing and getting ready for the ownership.
Thank you so much. See why it's important that everybody should talk. You know, oftentimes some of us are quiet. We will not talk until we are prompted. See what Abia would have taken back home. Lagos State feel challenged. Lagos State want to respond. Please, can you give it to your friend from Lagos State? Menti, are we ready? Thank you so much.
Good.
Please introduce yourself.
Yes, good afternoon, everyone. I'm the LMCU coordinator.
Can we have one house, please? One house. Let's respect the person with the mic. Over to you, please.
Okay, my name is Pharmacist Margaret Adedapo. I'm the LMCU coordinator, Lagos. Just to add to what's been said, so Lagos for 2025, in the last 6-7 years, Lagos has been consistently procuring test kits and consumables. So let me just say what was done for 2025. We've had not just the approval, but the release of funds, and we have been able to procure test kits to the tune of 87 million. And then we also had support from the Saving 1 Million Lives project to the tune of about 12.5 million. So all these test kits and consumables have been procured for 2025.
Thank you so much. A round of applause for Lagos. So we have 2 states that have actually procured test kits in this, despite the stock out of test kits. Your test kits, are they under drug revolving funds or they are free? They are free. So patient does not have to pay a dime to use the test kits.
They don't
Same
pay
as Abia. Which other state has procured test kits? Approval and release, the ordinary approval.
Approval and release, 5 million naira to procure test kits. Just 5 million. At least it's still part of it.
A round of applause for Ekiti. Do we have another state that has procured test kits of approval, no release? Speak up.
All right. Okay, for Mondo, I would have appreciated if the chairman was here, but since he's not here, I don't have the details of how much it is. I'm TB, but I romance my HIV person very well. But it's not here. He's going to give you the details. But I know that there's been an approval for the procurement of test kits. I know that, but I'm not sure whether if it has been released or yet.
Okay. Oga, Nasarawa, you've procured test kits? And your test kit is free, or is it under the drug revolving funds? Okay, please, can you tell us how much?
How much what?
How much you procured now? Abia procured 90 million. Lagos, 100 million. Ekiti said did 5 million. Something.
Okay, so I think for Nasarawa State, about 40 million for HIV, and I think about 40 or 50 million for hepatitis. So combined, I think we have about 80 million or 85 million thereabout. Thank you. And for TB, released, because what was approved, or the memo that we wrote for HIV was around 50 something million, which was more than 3 times what was budgeted for. What was on the budget was a meager sum of 50 million, but we were able to mobilize funds from other areas, and then we got up to over 50 million. Same thing for hepatitis, and all the money have been released. And also TB too, 30 million was released for TB, and we're able to get commodities for that as well. Thank you.
A round of applause for all the states that are contributing. Which states? So please, where is the Kano 2? You think Abi was released? In 2 minutes. So that we go back.
So because of this integration, we are now married. So I think my name is Dr. Suleiman Musa Kofa, the program manager, Kano State Tuberculosis Program. Because of this marriage, I can be able to speak for HIV in my states. Our governor, who is a public health physician, a consultant, who is also passionate about HIV, TB, not only HIV and TB, all the diseases of public health importance. I think HIV, we had a procurement of HIV testing kits. I think the money that was released was 50 million naira. And then the test kits was actually procured. And then some millions of nairas, I can't recall the exact amounts, was actually released for the procurement of some commodities that we use in TB.
Thank you so much. Please, a round of applause for all the states. We cut that because that wasn't actually what we wanted to discuss. It was just in warming us up. But out of our discussions has come out something very important. For NASCAP, I was trying to look out for the data person. We will try to look at, we are expecting that all the states that have test kits, it should reflect in your data. So it should reflect in your data. We've noted it. So we expect that we will see changes in your data for Nasarawa, for Lagos, for Habia, for Kano at least. Then as we are preparing for GC8, please, all these documents, the one for release, the one for approval and release and all that, please gather them together. They are all important. They are part of our counterpart funding. Please gather them together, put them in a file. And if you can actually share them in maybe with NASCAP or thereabouts so that we have this information for us to be able to use going forward. Please, let's give ourselves a round of applause again. I wonder what happened to this place. So what happened? From where? They didn't go to pray? No, they are not Muslims. Please, can you call them, please? Okay, so we have we are back to where we stopped, and I think we should continue from there. So please, I will hand over the mic to you for you to guide us through. First, people should log back into their Mentimeter. You know how that is done, right? And then help us to read that question so we can proceed. Thank you. You mentioned your name as well.
Okay, thank you. Thank you. My name is Timzing Miridashe. I'm the IHV Regional Manager for Jos region. So at this point, I hope that everybody has logged in. I can see bullets coming in. People are voting. Please go ahead and continue to vote. So the question is, what capacity gaps exist among health workers for integrated service delivery? And so far, we have 31%, limited cross training on the multiple diseases. And we have 70%, but 71% already of our burden staff with competing priorities. And then we have only 4% lack of integrated clinical guidance. So we have inadequate supervision and mentorship structure taking about 12%, and none of the above is zero.
Please, how about our people online? Have they joined? Are they using their Mentimeter? Please help me to call them.
Please, our online participants, kindly indicate. And can we show what they're doing, their participation so far?
Yeah, we are
somebody help us with that?
Yes, I voted online, Nicholas.
I voted
right.
too.
Okay, so online people are voting already.
We are more than 50 in the room, but we have just 44 votes. What's going on? PVC. What does that mean? We have more than 50 people in the room. We have just 45 or 44, 48. We need more, please. The earlier we start, the better. Please vote, 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 vote. So we have a lot on overburdened staff with competing priorities. I can imagine. Can we unpack it? Can we look at that just for a minute? Yeah?
Yeah, okay.
Okay. So let's move to the next. We still get to. Thank you so much. Please give a friend.
All right, thank you.
The next question, please.
My friend.
Please vote. While you are voting, let your friend come up to help us to read it. Oga from Oshu. Oyo. Please come and help us. Lagelu local government. Help us, sir. Please introduce yourself.
Okay, I'm Dr. Wale Falana from Oyo State. Okay. What strategies can improve coordination and task shifting? %, develop integrated training curricula. 50% implement supportive supervision models. And 6%, okay, it's moving though. Okay, it's going back. And the next one, empower community health workers.
Chief, they said they can't hear you. Drop the mic so that.
Okay, can you hear me now? Maybe hypoglycemia. Okay, what strategies can improve coordination and task shifting? Can you hear that?
Yes, go.
Good. So for now, 11% voted for develop integrated training curricula. We have 11% implement supportive supervision models. 6% empower community health workers. 72% harmonize job descriptions across programs. 0% none of the above. So
thank you so much.
So 72%
takes the
72% harmonize job descriptions across programs.
Thank you so much, sir. Please, we have just 36 responses. We have 151 persons. So please, we might not be able to move from this unless we have at least 50 votes. No, it's there. 488-2469. The Mentimeter. Please help us to return the code. Some folks need the code. You've not been voting. You would have thought. Hey, yeah. You see why it's important to speak out. You still have it. Chairman, please, can you quickly use so that we can move? Should we wait a minute or move on? Okay. Observation. Please give her the mic. We don't have a lot of minutes more. We have just 15 minutes to 3. And we are still going to phase 2. So please keep it snappy. Microphone.
So I think there are concerns about this question. There are two questions in one. And, the way it is lumped together. I feel it would have been best if we separated coordination and task shifting, because they're two different issues. And then the option of even all of the above might have been better, for us to be able to do this. But separating the questions would have been better, the issues, sorry.
Thank you so much for that feedback. We agreed that there should be a sheet of paper, Abi. Please help us to write. Put your name, your comments, if you think that this one is all of the above or none of the above. Taiwo, please, can I give you that responsibility to help us to collate all the... Thank you. We actually have a response from Francis PM, Dr. Francis, PM Delta States. How can we ensure sustainability? So we have a sample. The person said should have added and government release. That wasn't just about approval, but release. So please help us put So it's not just even about the question, but also put in what you think should be your own answer. That one would actually help us. Should we move on? Thank you so much for that. Should we move on? Online family. Online family, should we move on?
Yes, move on. Oh.
Okay, please, can we move on? Next question is on service delivery. Next question. Madam Comfort, please, can you help us to read?
What opportunities exist for integrating service delivery points? Okay, so we have co-located services at primary healthcare centers. We have one-stop shop models for HIV, TB, and malaria. The use of outreach/mobile clinics for integrated care. Then we have integration into maternal and child healthcare services. And 73% for one-stop shop models for HIV, TB, malaria. We need more responses from everyone.
How many do we have? 29?
Yeah.
Oh, we need more than 60.
More than, yeah.
As now, if only 2 persons vote, then no, so that it gives you some clarity. It gives you clarity.
No. Let's keep voting, please.
Okay.
More responses.
So your Mentimeter as well? Come and explain it.
So on your Mentimeter, whether you've selected your options or not, just scroll your phone up, then you see a section too that says send a comment. Send a comment. So you can, after your selection, you can go to send a comment, type in your comment there, and then you will now submit. So you'll be able to have much more of your information being commented on, and then the coordinating people will see it to collate it together. Thank you. But however, I'll still be going around to get the paper. Thank you.
Thank you so much. Madam Comfort, thank you so much. Can you give it to your friend? 74 over 165, 9. That's good. Give the phone to a friend. All those Gombe people. They are supposed to be your friend. We've been implementing in Gombe.
I should go to the back.
Gombe was here now. He left.
Okay, yes. Since where to go to?
Eh?
Gombe.
Jumatke. What's it did now?
There's Gombe here.
Oga. Come to the front so that we can see you.
All right, all right.
Because they said their Gombe didn't come. Me, I know I saw Gombe. Thank you. Okay, next, please. Please help us to read.
What are the risks or barriers to integration? Increase workload without additional resources at 0%.
Please be voting no.
Confusion over roles and responsibilities, 0%. Data management complexity at 0%. Oh, okay. Resistance from vertical program structures at 29%, and none of the above, 0%. Confusion over roles and responsibilities is raising to 19% now. Increased workload without additional resources at 31% now. There is an increase in resistance from vertical program structures to 50%, to 52% now. Is it okay, Ashwa? Yeah, I have them. My phone is there. Yeah. All right. It's okay.
Give your friend.
All right, my name is Dr. Zaradin Bapoyo Adams. I work with Society for Family Health. Thank you.
And yeah, give a friend. Gombe friend. A round of applause for him. He's yet to vote, though, so don't remove it. There are some people that still need to vote. Online family, are you with us?
Yes.
Only 1 yes.
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 Should we move on?
Yes, let's move
Gombe,
on.
have you voted?
Yes, so move on.
Please give your friend and then let your friend come and give us the next. Oh yeah, fast. Thank you. Exactly. Next question, please. Mentimeter. Please be voting as is reading. Be voting as is reading so that we can close early.
So how can we harmonize data collection tools and reporting systems? The first one, develop unified registers and reporting templates, which is at 100% now. Align indicators across programs, that's 0%. Use interoperable digital platforms, 29% now. Train staff on integrated data management, 4%, and none of the above at 4%. So develop unified registers and reporting systems, rising, and is the highest now, while none of the above is still at 3%. So please vote.
From here. I changed the seat. Have you voted? I voted. That's what I'm going to vote.
Please vote. We still have develop unified registers and reporting templates at 53%, still the highest. Align indicators at 13%. Use interoperable digital platforms at 26%, and train staff at 8%. We have 69 responses, 70. So that's good. All right, so I'm Dr. Estefano Zaluke. I work with LTR, Leprosy and TB Relief Initiative. We are an SR under HVN.
Thank you so much. The next question, please. Dr. Edewo, the next question. That's access to essential medicines.
All right.
Next questions.
Yes.
Mentimeter.
I'm here. Is there?
Okay.
Oh, okay. I thought that was the next question. Okay. So the next question is, what indicators should be prioritized for monitoring integration? What indicators do we think should be prioritized for monitoring this integration we've spent the 2 days talking about? All right, so far we have 48% for service uptake across diseases, 16% for co-infection screening and treatment rates, 13% for health worker performance or integrated tasks, 12% for patient satisfaction and outcome. So service uptake is actually increasing now to 57%. And all the other options are between 11 to 17%. Service uptake is still on the increase, currently 62%, while the others are still in their teenage level. So I think most people are still supporting service uptake across diseases, 63% currently.
Thank you, Dr. Edewo. Please give a friend
a friend
for the next question. A friend that has not held the mic.
Let me see who has not held the mic today. Yes, my beautiful friend has not held the mic any day.
Next question, please. Alaja. Oh, yeah.
So next question is, what data assurance processes should be integrated? So we have data quality assurance at 22% now, integrated supportive supervision at 15%, then joint program review for ATM at 41%, integrated dashboard for ATM 29%, none of the above at 0%. So bots are still coming. Would join program review for ATM that leading with 46%. Votes are still coming. Continue to vote, please. 45, 72. So votes are still coming. We still have joint program review for ATM with the highest votes. Joint program review for ATM, 53% now. Where are the comments? For the online votes? Okay. Okay. So they should show it. Okay.
Please, can you show the charts? I think there are also some comments from online.
Online votes.
Aside from the votes.
Once the dashboard is available, the review meeting will come. Which dashboard? I don't know. These are charts from online participants. So I think that's all.
Thank you so much.
Yes.
Give a friend. You didn't introduce yourself.
I am Dr. Umma Abubakar Isa, SAPC from Kano State.
From Kano State. Welcome, madam.
Thank you, ma'am.
Please, can you give the microphone to a friend that has not held a hand? He has not spoken since.
Okay.
Next, please.
Okay. what challenges exist in aligning supply chain system? So I said what? So please, can start voting, please. We have number one is okay. Separate procurement and distribution channels is having, but still people are voting 75%. That one. Then stock out due to poor coordination, 3%. 14% for lack of integrated okay. Lack of integrated forecasting tools. Others. Then online, please, any comment? Online participants, please, any comment? It seems as if the voting has ended. Oh. Yes. The highest here is the first one. Separate procurement and distribution channels. Okay. It's still moving up.
Thank you so
Okay.
much. You did
Elena?
introduce yourself
I am Said Abubakar, the SAPC for Bauchi State.
from Bauchi State.
Yes.
You are welcome, sir.
Thank you.
Please,
Yeah.
can you give a friend at the back? A friend at the back. The back. The back. The back. Thank you. Please keep it coming. Ekiti is your friend. Ekiti, give somebody else. Ekiti has been active. Ekiti, give a friend at the back. Give a friend, Ekiti. Let's be fast about it. Give the bishop, Nze Brothers. Please, as the person is coming up, let's be voting. Please, let's be voting. Please, let's be voting so that we can go on time.
Okay, so how can we improve forecasting and procurement? Currently, we have joint quantification exercises at 50%, centralized procurement planning at 14%, use of integrated MIS platform at 27%, regular supply chain review meeting still at 0%, and none of the above at 6%. Currently, we have just 23 persons who have voted. I haven't, so I'll probably make 29 when I do. For our colleagues online, please do well to vote. We're at 44 persons now who have voted. We expect to get up to 70 now for this particular question.
Thank you. Let's keep it coming. You did introduce yourself.
Okay, so my name is Tanze Samson Silas. I work for Reddit Nigeria as the STO for Benue State.
Thank you so much. Let's keep it coming.
We're at 63 persons now, hoping to get up to 70.
Can we keep voting? We've had more than 70 response before, but we are not even up to that now. Please, so that we can move on. There are comments online as well. Could you read that?
So there are no comments actually.
Okay.
Yeah.
Please, can we move on? Can we not move on yet? We need 70 responses before we can move on. Please, let's keep it coming. We are almost there. We are almost there.
That's 70.
Please, can you give Nze brother?
Okay.
All right, thanks. God bless you. Okay.
Okay. Okay. I speak to that.
Thank you
All
for
right.
giving me the opportunity. If we go back to the last question, the analysis of the last question, can we go back, please? Okay. In the options, we can see joint quantification exercises, and we can see centralized procurement planning, and we can see use of integrated logistic management information. That is LMIS. So if we have logistic information system platform that is joined, will give us exactly, it encompasses almost all the other answers. So LMI stands for Logistic Management Information System. So if we have integrated LMIs, it will take care of that. Thank you very much.
Thank you very much. Just to add voice to the integrated LMS platform, we already have the NHLMS, the National Health Logistics Management Information System, where data from HIV, TB, malaria is already being reported on by the facilities. So I just wanted to say that it's in existence. What we don't have is probably a CRIF, like, the electronic CRIF is not what's it called? It's not unified, but the NHLMS platform is, we have where every program reports on. So we have something like that already. Thank you.
Thank you. Please, let's give ourselves a round of applause. Some people didn't clap. I don't know why. Please, let's give ourselves a round of applause. We've done well. When you've done well, you should pat yourself at the back. It's for all of us. And the reason we are giving ourselves a round of applause and the pat at the back is we finished round 1. So I want us to quickly, and this is where the decision is. I want us to quickly go through that. It's not a lot, we quickly go through it, and then we can now have the award, the different levels of award. Mentimeter, please, can you go to part B? Nze brothers, please. Okay, so please help us to. Yeah.
Okay. So related leadership and governance, long-term institutionalized integrated governance models across all levels of the health care. The medium term, okay, we have long term, the medium term, and the short term. So I think long term, I think has the most.
So let me provide more context. Now, whatever we rate here is what we would. So if we say that we want to have established coordination, blah, 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 in the short term, that means from today, the next meeting we are having, we are planning that, right? So is a yes or no, is a ranking thing. So the one that you think should be what we should start, right? So we should rank it so that we know what we are doing short term. But if we don't get enough responses, it will be difficult. So
okay.
Yeah, so we can start. Short term. We have short term, we have the medium term and the long term. To establish the coordination structures, example, the joint task forces, integration communities, etc. Now, for the long term, we have institutionalized integrated governance models across all levels of the healthcare. And the last, which is at the medium, is to develop and disseminate integrated policies and strategic framework. So,
Thank you. Inza brother, please stay with me. How many responses do we have? So while the voting continues, how do we want to do the short term? And this is for the states: TB, HIV, SACA, SASCAP. The responses we want is from the states. How do you want, when and how do you want us to proceed with the short term? Yes. Please, do we have somebody taking notes? These are decision moments. These are decision moments. We need somebody to take notes. So if we decide that starting from 1st of December, we will need to work at creating or establishing a coordinating structure, then we'll give ourselves when do we start and when do we expect to have it finalized. These are decision moments, please. Who's taking notes, please? 3 persons, thank you.
I think for the beginners, if they go for the short time, it is okay. All of us here? Okay.
In the next few months, right, you want to establish coordinating structure. Then how do you want to go about it? What are these? Do you all agree? Is this something that you've already said you agree by the ranking that you gave it?
Okay.
And then what timeline do you want us to put ourselves? And it's like charging ourselves, say that we've decided amongst ourselves, all the SASCAP here, all the SAPCs here, all the TB folks here, that we will do this in the short term. So we'll be holding ourselves accountable to this.
Thank you very much. This have to do with the clarity of the state. Like in my state, already we have a strategic plan, 5-year strategic plan for integrations of these ATMs. So already we have an existing agency. We have our strategic plan. We have our normal work plan. We have our AOP. Do you understand? So on this, we take, that one cannot, short time cannot apply to our state. Only long time can apply to our state. Thank you.
Thank you. Bauchi already has done work on short term. Chairman, do you want to speak to this? The 2 chairmen? The short term? Or you don't agree? You voted. We voted. Eh? We voted, sir. Okay, sir. SAPC?
Good morning, everyone. Just like my Bauchi counterpart said, already in Kano, we've already established the coordination structure, and we've commented that I'm the chairman of the TB HIV TWG meeting, and it's consistent. We've been having quarterly meetings where we address the gaps in care, either services where HIV services are not provided for TB patients or HIV patients are not providing with the TB care. And then also even the logistics, we address the logistic issues, we address consumables, we address all cross-cutting issues, and we made sure that even if we go for joint supportive provision, whereby we make sure that we input TB services, and also when TB is having their own, we also conduct our own. And then even our consumables, we don't separate them, because initially when I came, they would tell me, this is TB test kit or TB consumables. So we have removed that barrier.
that anything, if the TB program needs our consumables, let them use it. If we need TB consumables, let us use it. So already
Thank you. Do we have states? And that is why I came to the chairman. Chairman Saska, Chairman Saka. I don't know if we have the chairman for TB. I think you were the one that gave the keynote and spoke for them. That's why I'm coming here.
Okay, thank you very much.
For us to make that decision.
Yeah, you know, like
We've actually said, when we looked at the rating, you know, earlier on we talked about what the challenges are. We had some questions, but now is decision time. And we all decided that in the short term, this is what we can do, right? And because it's a lot, it doesn't mean all the others are not important.
All right, so
But we are saying that when do you want to start? Because everything that is here will be held accountable for them.
thank you very much, Dr.
Subnational, sir. That's why they are the ones voting.
Thank you very much. You see, Bauchi, Kanu, they got it very right, especially Bauchi. From time immemorial, all these programs are under one agency. So it was just very simple that the institutionalization of this program is already clear in the government at a Bauchi level. Same thing will go on there. So why, for most of the state, these coordination structures, they are already from almost 2 years. We have been talking how we get this thing. We have passed that level in so many states. So the next thing is the policies that can now, that's why I voted for medium term, because it is that policy that whoever is the head of the health institution, especially Ministry of Health, has to what? Agree that this is what we want to get going forward. So everybody knows what is going to be their contribution for this integration to happen. That is why the development and dissemination of the integrated policy is very, very key, because the various coordination platform, we have activated them and tried to work. But we need the government person at the top to say, this and this are okay. Because as civil servants, work with policy. Do you understand? Because if you are working with policy that have been endorsed by, or even at the federal ministry, all these things we are talking about, if the coordinating minister does not endorse any of these proposals we are bringing on board, it will lie foul.
Okay,
so that is why at the I don't like that language, subnational. The language I know we use is state.
Okay.
Because when they are talking of budgeting, they never tell you what is called subnational in allocation of our resources. So most of us will have to develop the policy about this integration so that it can work well in many of our states. Thank you.
Thank you. Thank you. So we have in the medium term, development of policies and strategic framework, right? Is it an agreement across board that is the first thing we want to do? Is this an agreement? Please, we need people from the states. This is a decision that you are collectively making. And it's something that will go into the minutes and we will say, we would actually ask us when we are writing the grant, because it's important. What are those steps that we've taken based on our agreement? So please, are we all in agreement? If you are in agreement that the first step we should take is develop a policy, right? Please raise up your hands. Are you governments? These decisions are for the governments. Please, can we, how can we get this information how can we collect this information? For this agreement that we all reached in this room. No, let me give Anambra first, then I'll come back to you. But few minutes, we really need to close.
Thank you for the opportunity. I said there's one thing I want to add to this. You know, the National Council on Health is coming up. And if we can bring this thing up here, write memos based on this, it can come into it and states will now start adopting them. So I think it will help.
Okay. So NACA, are you taking note of that? Or who is in charge of National Council on? No, yours is AIDS. National Council on AIDS. So we expect that we should get memo from all of the states here and states that are joining online so that we are able to take this forward. Chairman, you said something. I think I want to hear your voice as regards this.
You see, we need to understand that for TB is simple. You know, they just need to integrate with HIV. But for HIV, there's integration within HIV. NACA and NASCAP, SACA and SASCAP. So there's a problem there. You understand what I'm saying? So without a policy at the federal level or national level, it's not going to work. Are you getting me? Let there be that integration and it comes down to the subnational level to the states. It's simple. For the local government, it is easy because the LACAs are strictly from primary care. You understand what I'm saying? But at the state level, it is not easy. There are agencies at the national level.
You, sir.
So in a way, if you're looking at the short term, what you can do probably is to also develop indicators to monitor the integration that you're looking at
So
for TB.
Get there. We still get there.
All right, so that's things we need to do. All right.
Yes, sir. So health is on the concurrent list.
Yes.
And all the state governments actually have that power. So when we actually throw it to the national to say the decision should come from the national, are we trying to say we don't have that capacity at our level to make those decisions?
No.
Is a question, sir.
Yeah, thank you. For several states, we look up to the national.
Okay.
People want to already look at models and states around. You understand what I'm saying? And if it's not on the priority of we're not bringing it up, even within the states, the governor is not going to do anything. That's the truth. Thank you.
Thank you, sir. So thank you. We have that. Please do not take us. We all agreed that there will be memos to the NCH, right? As regards having a policy that calls for ATM. Is that correct? Is that correct? Is that correct? So we should, sir? Eh?
Just permit me for 1 minute.
Yes, sir.
So that we don't leave here with the wrong information. We have only one HIV response in Nigeria. We don't have, there's nothing like integrating HIV. You can integrate HIV with malaria or TB or NCDs. So we have one response. We have one response for HIV. When we are talking about leadership and governance, NACA is responsible for the multi-sectorial response. In fact, NACA is supposed to galvanize funds and give to the health sector, which is NASCAP, and also give money to the Ministry of Communication and Information through National Orientation Agency that has to help us with the passing information to the rural communities on how HIV is transmitted. NACA is also responsible for the child health education of HIV. That's Ministry of Education. NACA is also responsible for dealing with the armed forces. That's why I have in the police, army, and others. So there's one response. What we lack is coordination. Please, let us not live here with the wrong information. And because of that, if you get to the story of how NACA came, it was when Olusegun Obasanjo then, because we are looking for how to respond to
the epidemic of HIV, that also PEPFAR started with South Africa. He decided to raise money to take care of 10,000 Nigerians with HIV. That's how that response came. And that was how NAFCA was initially under the presidency. So let us not live here with the wrong information. Please.
Because you asked for 1 minute, sir. Sorry, sir. Sorry, sir. Yes, sir. So, Mentimeter, you've taken notes of all the comments in the room. Please, can we go to the next question, please? The next decision. Eh? What happened? No, me, I'm talking to you.
Malaria, TB, HIV will not emerge in it until you resolve that. If I said now that poison the shoot. We are talking of NC. It's not the meaning of NC that we live now. NC is also member.
Health financing. One now, so thank God the two chairmen are on the same table. Please help me. No, they are not fighting. Help me serve them water. We need to leave here early. Help me serve them water. So health financing. So I need chairman. Chairman, please help me, sir.
Okay, health financing, short-term map existing funding streams.
Please vote.
See from here.
Go on, sir.
Identify overlaps or gaps. There's no percentage there, but it has I think the highest. Medium term, advocate for pooled funding and integrated budgeting mechanisms. Long term, transition to sustainable domestic financing models, e.g. inclusion in nation, right? Done.
Still hold the mic, because we still need more responses, sir.
Okay.
You want to tackle him? He has gone. Leave him for now. So please, we still need votes while they are coming in. So you think that we agree that we can map existing funding streams and identify overlaps or gaps? Is it a decision?
Yes.
And when do we want to do that? When? Not what I mean by short term is when?
Can be done immediately.
December,
Yes.
January, February. We will do it between now and then.
December.
You do it in December. In all your states?
December.
So who is going to be responsible? Who are we going to hold responsible for this mapping?
SACA and TB.
SACA and TB. Okay. SACA and TB has agreed that in the next 3 months, so we are giving ourselves from now till December, that we will map now. Malaria. That's true, malaria. We almost left them out.
Okay.
Please,
Maybe we need
the note takers, please, have you taken notes? Chairman has committed to that and we'll run with that. Chairman, help me. Chairman, she wants you to reiterate, sir. Thank you, sir.
I said December.
Okay. By December,
We're going to map existing streams and identify overlaps and gaps.
and gaps for the 3 diseases, HIV, TB, and malaria.
No. You've added malaria now, so we extend it to January.
To January, that's fine. That's fair. That's fair, sir. That's fair. The second one, is it medium term now? It's a medium term now is like we don't want, or what? Medium term, sir. Is it possible? Let's even start with short term, Abby. Yes. If we do that one, we'll pat ourselves on the back and then we'll move on. Thank you very much, sir. The other chairman, he stepped out. Please give your anybody you like, sir.
Anybody I like.
Number 3. We need to move fast. Number 3.
Okay, number.
Are the awards ready, please? Those that are giving awards. Naka, NASCAP, Naka. Please go on. The awards. They are not giving again.
Number 3, ranking health workforce. The short term is to conduct joint training on integrated service delivery and data tools. I think the voting is just beginning. The medium term is to harmonize job descriptions and supervision structures across programs. And then the long term is to build a multi-skilled workforce with career pathways supporting integrated. So I think the short-term approaches are carrying the day.
Thank you, sir. How do we go about it? We have just 20 votes, so we really cannot conclude. We have just 20 votes. We need all the state managers, TB, HIV, malaria, any program manager that is here. We need you to have those votes. And then, please, how do we go about it? How do you want us to go about short-term, conduct joint training on integrated service delivery and data tools? Ebony, please. Okay.
Most of the jobs that are being done by non-government staff. So I think the first thing is for TB, most of the people that are delivering TB work are government driven. For malaria, the same thing. But for HIV, the workforce is in the non-governmental space. So there is need for you to first harmonize that job description within the HIV space first.
Okay. Can you speak up?
Okay.
Looking at what we have here, I'm of the opinion that in the 3 vertical disease spaces, most of the workforce that deliver services in the TB space are government-dominant staff. The same thing in malaria. But we need to put into cognizance the fact that majority of the people who work in the HIV response space belong to the non-governmental sphere. So if you are training on integration, most of the workforce in the HIV space are from partners, IPs, the technical arms and all that. So the first thing to do in the HIV space is to harmonize that job description beyond what you are doing at the moment, what is expected of you before you go into the space of training them for what they are supposed to do. Because now if you are training beyond the scope of what they are delivering at the moment. So if you are going to be looking at these, I think it needs to be disease specific. We cannot just be generalizing. We need to put into cognizance what is operable in vertical disease implementation spaces. Thank you.
The job
for HIV.
Yes. Who else agrees with him? We all agree. So that's the first thing that we'll do. Please, cheers. The decision is that we should do job aid first. Yes. When are we going to start? Oshu?
I think once we get back, immediately we should start work on it. Although in the same medium, give ourselves the next 3 months because we need to now, there have to be meetings. The 3 programs have to be involved and we now harmonize job description. Before anything can start, there must be job descriptions and everybody know what you need to do in order to achieve success.
Thank you. So I assume that job description is for the health sector or is it for everybody? Particularly for HIV. So we all agree, Abby? We all agree. Hey, the room is cold. Don't say brothers. Okay.
They have conducted national training on it.
That's the training. We are looking at the job aids,
yes,
job descriptions.
Even with services integration, I think in 2010, National Primary Healthcare have something similar to this. Because, yeah,
So we must have job description for the HIV workforce.
Okay.
The government health workforce up to speed. All right, and then we can now talk about the HTM alignment.
So we agree, Abi. So are we going to hold responsible? The two chairmen, I don't know if they've gone out to actually brainstorm on this one, because they were tackling themselves. No be small something, no. Eh? But we need them to make decisions. When?
Okay. Okay.
You know that fight where it's no fighting.
No. This is a house of peace. We cannot afford to. Please, sir. Please, sir. We've made some decision. Job aids for service delivery people, it needs to be harmonized. We have it already harmonized for TB, for malaria, but we need to clearly articulate what we want for HIV. And we all agreed. So we were waiting for you because we would hold you responsible. Both of you, please, can you put their names? Chairman SAPC, Chairman Saka, so that both of them, when are you going to finish it? When should we come back?
For job aids.
Yes. That medium term, there were issues that were raised here. Come to the front, sir. Come. Chief, Doctor, please come, Adeloye, please come, sir. That is why it's a difficult conversation, but it's also a simple conversation. You want TB to also join? TB, sure you are the one that gave speech for TB. Where's that organ now? Please help me look for the TB focal.
And where's malaria too?
Malaria will join. They are not in this meeting, but they will join. Leading us in the direction to go, and we are holding them responsible. Please give them a round of applause. Thank you so much for that. Thank you, sir. Can we go to the next? No, January now. 31st January.
No.
It's too far. Emma to Taposi.
Let's be practical and realistic. We have a lot of activities here. You are setting like 3 different things and you are giving us timeline of January.
But when do you want? That's the.
Which chairman?
It's true. They went outside to sort something out.
We need to be
financial.
Chairman, when should we come back to you?
So give him this one. No, I have earlier said that policy development have caused that for the proper integration and the marriage. Now, that's why that policy development and dissemination, all these things you are talking about, job aids, they will be spelled out there. What do we want that they cannot bring? Because the point we have tried to run away from, which we carry it outside, is there. From what Dr. Ali
You refer to that.
No, I'm coming. No, that you see. About that fish bone and all these things. Let both NACA and SACA understand their role, and then SASCAP and NASCAP understand their role. Why is the health sector respond the one causing problem? Why are we not hearing anything about line ministry like Minister of Education, OVC, line ministry like Minister of Youth and Sport, line ministry like Minister of even Women have, no, that is, women have education. All these things are line ministry for HIV activities in the country, that NACA and SACA are the one coordinating them. I remember when I came in newly as SAPC, our validation meeting is organized by them. Any data we generate,
together, those things that once we pull them together, we give us the greatest return. We make things more efficient and effective.
Yes.
Those are those things that we are talking about. And truly, it doesn't mean that we have to agree 100% on something, but we can't come here all the way from Kano, Bauchi, Utuwenji, and we are not going back with decisions. We are tired. Some people came and said, Doctor, we are tired of coming and discussing all the time. We want action. And that action sits with you. Please sit down, sir.
No, I won't.
You don't want to sit on that table. Sit down.
All right, so thank you. No, let me see. So what is there? This is the way I see it. Like you're asking for job aids. I expect NACA, SACA, and that's okay. And NASCAP and SASCAP, you are in the health sector to respond. What are the job aids that you think we can also facilitate? We come together. Hey.
You will do that. You will do. So when Dr. Adegbulugbe said that by January, support, maybe facilitation and all that, we will look at how best to ensure that January that the SACA has committed to will happen. And we'll keep on holding him responsible, even up to the ministerial level. So it's not that here is when we are going to have the nitty-gritty of how it's going to work. Please, do we all agree? Please, I want us to close early. Is he on this one? Please, can you keep it short?
It's going to be very short, but it's very important also. I'm not going to start telling anyone what to do. So I represent LMCU coordinators across the state. We can also draw, insights from what happened. It didn't start overnight. In 2016, the Federal Ministry of Health came up with the fact that there should be the supply chains of different programs should be integrated. So integration will not start with a block of things. Integration starts with the low-hanging fruit. What did we integrate? We started with the integration of the LMIS. That is why on the Nigeria Health Logistics Management Information System, you will have HIV/AIDS, malaria, family planning, TB, PMTCT. And as I speak now, there's a move to integrate nutrition, MNCH, essential medicines, so that at a go, you have everything. That is integration. That is where we can, at least we have agreed on that. as a nation. And that is what we are doing. And everything is in one space. We have a logistics management coordinating unit across every state of the country. We started with 14 pilot states in 2014. Right now in 36+1, every state has. Whereas we are at different levels of strengths and all that, but we continue to. It doesn't mean we subsume any program or any, so we can also learn lessons from that. So I was looking at when you say integration of quantification, I laughed in my mind. I didn't pick that because that would not work. So for those that are in the national quantification team for any program, for a whole week, you're sitting down and racking your brain through to know even the forecasting elements. The next week, yeah, even at that, people still have to crunch. So you can't really sit down and say you want to integrate all the quantification for the different programs. Yes, there may be a set of people doing everything together. So you see, when this issue about NASCAP, SASCAP, or SACA and all that, the integration I know may happen is looking from that, look at the low-hanging fruits. What can be integrated? It's not like one is going to subsume the other. That will not work. Thank you.
Thank you for your contribution. Please, a round of applause for her. Thank you. So how many have we responded to? Mentimeter. How many have we done? We've done 3. Okay, so please, can we do 4? Mrs. Oladapo, please, can you help us? Adedapo, please, can you help us with this? Thank you. Please bring your phone so that you can vote.
Okay, so I'm the LMC coordinator, Lagos. Margaret Adedapo is the name, pharmacist. So ranking service delivery. So we have short-term, identify, and pilot integrated service delivery points. For example, one-stop clinics. That's short-term.
We still need more, or give me range of the votes, because it's not everybody that is.
So I think we have voted in that order. I want to believe, yes. So 1, short-term, identify and pilot integrated service delivery points. Then we go to the medium-term, scale up the integrated models based on the pilot results and feedback. And I think it just stands to reason. And then long-term, embed integration into national service delivery standards and quality assurance systems. Thank you. I don't know how many people voted. 6. Okay, 45 out of 165. Can we vote? Can we have more votes? Yes. For those that have not voted, please. Only 45 people have voted.
Thank you, ma.
You omit yourself, then you chat.
Or
Later,
what do you
this one.
Do you have anything contrary?
So I guess total
Okay,
participation.
so once we do the policy, I think it would allow this. Can we move to the next place? Processes.
OCC. Live transcript can again.
Number 5, Mentimeter.
5. How about fighting?
Please, let's keep it coming. Let's keep it coming. We have just 2 persons. 3. Let's keep it coming. Health informatics. Should we harmonize data collection tools and reporting formats? Should we develop integrated dashboard and analytics platforms? Should we achieve full interoperability of digital health systems across the disease programs? Please, let's keep it coming. All of the above, put it in the comments. Put all of the above in the comments. There is a comment section. I think there's a comment here. This is comment, right? Please, you can put it here, all of the above and all. Please, we need more response so we can move on. So we can move on. I think we've started something on this, especially the dashboard. Do we have any information as regards that? On the dashboard, I know we've started. Or we've not done anything. Dr. Moni, do you want to speak to this? I thought you wanted to. I know they've started something on the dashboard, integrated dashboard. I know that. Speak. Can you give the mic to Dr. Edewo? Fast, please.
Good afternoon once again. For Rivers, yes, there's been a training on the integrated dashboard. I'm trying to remember the name of the organization that came to support that process. It was for ATM and NCD. I think those were the 4 programs that were the key programs. And NTD also, so it's 5, not 4. That's
HIV, TB, malaria. So all the program managers, M&E officers were in that training, and we were taught how to visualize the data. I think one significant thing on that platform was the fact that we had significantly more HIV data to view. There was also TB, but there wasn't much on malaria, at least in my state. Thank you.
Okay, thank you so much for that update. So what it means is that we have to look. Bauchi?
Yeah, I think the integrated dashboard in my state was done in the primary healthcare through GGHN, EOCs. So they developed the EOC. All the data for the primary healthcare are there. And just of recent, they have built, the GGHN have built our Bakatma EOC. We are trying to integrate our services, the dashboard for malaria, TB, and HIV through that EOC dashboard very soon. Yes.
Thank you, sir. How many states do we have that are actually supposed to have integrated dashboard? All the states? Pharmacist Eric, is it all the states that are supposed to have integrated dashboard? Not all the states. So when do we expect action? Or is there an action that we should forget for this GC7? Yes, thank you. Please, can you give him the mic? The timeline. What timeline? Such that this, I know that a lot of resources has been committed to this dashboard, but it seems that we don't have. So can you suggest the timeline? Thank you.
No. When you finish with the state, then we'll give you all the information.
Okay.
I think there is nothing going on in the state now presently, but I think first quarter of the next year, maybe we should have something to do about the harmonization of the dashboard. First quarter of the next year.
Which state are you from? What's your name?
Yobe State, Dr. Jibril Adamu, the SACA Executive Director, Yobe State.
Oh, Yobe State. Thank you. Is Yobe, does it have the health sector response included as well? Or is that dashboard is only for SACA?
Yeah, I'm making an effort. It seems just of recent, I think the Commissioner of Health convened some meetings to have a meeting between the ATM and us in an effort to make the integration works and other things. But we're still on the process. But we agree to follow whatever the Commissioner decides and the other stakeholders. But we have not yet concluded. Thank you.
How many response do we have? Please, National, please give us the update while we close this.
So for the national, at the level of the public health department, we have a dashboard that is already being developed for the 3 programs. We've identified indicators that will be pulled into the dashboard, and we've already started sending data, and we started test running how it will look. And so we're adding state level and granular disaggregations, but the dashboard is live.
Okay, so that dashboard, does it include what Rivers was talking about? Because the expectation is that whatever you have on your dashboard at the national should include the states. So if they are not aware, how does that happen? What do you get?
So like I said, it's data, program data. So even state level disaggregations are included on the national dashboard. I don't know if that's.
It depends on what you're using. For HIV program that has an automatic system, is linked. They're working on it to link, and it's this dashboard we are talking about in Director of Public Health Office. Yeah, so it's linked to the electronic system. I don't know if it's NDAS or I don't know which of them, but I know it's linked to them automatically. So for us, because our own electronic system is down, we do manual exports to them. And the manual exports we do is inclusive of state data. So the planning is that when our own system comes up, it also continues live feeding into that place. But that dashboard, you see a very big screen in the DPH office. That's where all those data. Then they've done some training, was it 2 weeks ago? And also they've shown us live how it's going to be when it comes up finally. There was a training 2 weeks ago for all the programs, like the focal persons that are handling that feed. So there's a dashboard.
Thank you so much. You want to speak, sir?
Yeah, so for the indicators, the state dashboard, if they can, I don't know the indicator they capture, but it's possible that the same indicator you guys are reporting is the same indicator that the state is also captured on the state dashboard. So it make a lot of, it makes things easier. So if you look at, like she was saying, that the TB indicator on that state dashboard is minimal. So if you can help them so that they can have more indicator that can capture, what we have, so that we have national dashboard will be, the state dashboard will mimic what is also happening at the national level. So that would be good.
Thank you. So we have the last one. Please, can I cut it, please, because of time? Thank you. The last one, can we respond to this? The last one. While we are responding, I want to thank each and every one of us for being active during this session. It wasn't as difficult as expected. We know that there are still conversations that need to happen, and we do hope that when that conversation happens, we will actually be able to, it's not just about conversing, it's about us saying these are the steps that we've taken. During the communique will come up soon, and in there we would see few decisions that we have made. We all have made those decisions. Is it that we want to have joint DQA going forward? Is it that we want to have joint reporting going forward? Is it that we want to write to the National Council on AIDS, National Council on Health, about having a policy for integration, about the coordination, the importance of having a coordination mechanism, just like we have at the national, you're all aware we have the ATM, right? Are we voting? Okay. So these decisions would actually be shown back to us before we leave, so that we don't get home and we say, when did I agree to this? We all agreed here. Abby? We all agreed here. I know that it's time for lunch. So on that note, I want to thank each and every one of us again. Please, can you complete this so that we can call up the awardees? And while we are voting, I would like to call on the TB and HIV team, so that in few words, they would explain to us how they came about the ranking. The ranking we are talking about is the award. How some of us have been able to perform, across the different areas of our work. So I would expect that TB would give us in few words how we did the ranking, and HIV will do that as well. It's important we do this and then we go for lunch. Do we all agree? We are tired, I know, we've tried. So please, let's complete this. Please, we're speaking for TB and we're speaking for HIV. Dr. Obioma, is it you? Dr. Mercy, is it Dr. Mercy now? Who is doing for HIV, or is it Dr. Rhoda? Both of them. Is Dr. Chioma in the room? Please, can you come? You are in between us and our lunch. So please, let's give them 2-3 minutes to do that. Dr. Obioma, no, you are here. Is Dr. I wanted to call Dr. Chioma actually. Dr. Chioma, Dr. Mercy. Oh, you are the Dr. Chioma, okay. Dr. Mercy, Dr. Rhoda, please. Let's give them a round of applause. Maybe we can even stand up. Just a minute. Just let's stand up, please. Let's stand up, please. It's not good for our health. Let's stand up, please. No dancing, but let's stand up. Let's stand up. Let's stand up. You want to dance? They say they want to dance, so give them booga. Them no makosa. Give them booga, quick. They want to dance, so give them bugao. Oh yeah, now. Well done. Thank you, everyone. Is it not coming?
Wake up.
Vera. Vera, oh. Vera, go for them. So far, so good. Oh yeah. Buga one. Let me book. Let me see you the buga. Eh? Lo. Ga one. Lo. Buga one. Lo. Ga one. TB, are we ready? Thank you. Let's sit down. Thank you so much.
Okay. Please, can you put up the presentation? Thank you. And also cue the song, Stand Up for the Champion. When we call first position, so that everybody will stand up for the champion and dance. Okay. Have you seen the presentation? Okay. Okay, so from the aspect of the TB program and having integration in mind, please. Next slide. Next slide. No. The first one. So the key reason why we came up with this award, actually, not me, they came up with this award. Next slide. The first slide. Okay. Basically, because we know a lot of things happen at the subnational level, and whatever we speak is until it's implemented. Also in the subnational level, that's where we have opportunity for innovations, things that can be tried out, piloted. But this award, please, just note that it is not just based on indicators that you got the highest in child or this, it's all round. So it has to do with implementation of GC7 grants. Why I'm saying it is that I don't want you to take the zonal review presentation and start checking your position in all of them and say, I'm better than this state. So it's not just about those indicators. They count, but it also has to do the implementation, some bottlenecks that came out, how they took it by bullhorn. So some of those things we were discussing, there are different scenarios in different states, and truly not all states got back to the national wanting intervention. They also found their ways of making things work. Domestic resource mobilization, ensuring that there was enough tools. Next slide. So those are all put together to form this award. Next slide, please. Oh, I'm the one. Okay. This is putting together some of the criteria we used in the program. We looked at different indicators, laboratory, logistics management, finance management, absorption, retirement. They all came together to form this. So for quarter 1 to 3, we know a whole lot of our states did well. In fact, it's difficult to say which state is poor performing now with the situation on ground. But we also know some states who are not doing so much in terms of having to take ownership. So ownership is also part of the issue. And in terms of achievement, why I say it's difficult to say poor performing states, a whole lot of our states did above 90% to their target. And when you now check, I think we have about 9 states that didn't get up to 70%. And you know 70% is also a plus. So for the states that did the lowest, we try to, we know what exactly their issues are, but these are things we believe that if you take ownership, you should be able to also surpass those things. These are state retirement. We looked at the state retirement, those who turn around within 24 hours, 1 to 2, 3 to 5. So that's how the color code, just to tell you that a whole lot of things came in. So trying to put all these things into a platter. There are 2 sterling states that had green all through when you put all those. And that is Kebbi and Gombe. Those are 2 states that have stellar green all through, putting all this together. There's a 3rd state. It didn't have green all through. It had a little of a lemon somewhere, but it's the 3rd state in ranking. I want to talk about the 4th state. The 4th state is Anambra. Anambra, the difference between Anambra and, in fact, if not for quarter 1 happenings, there would have been a tie with the 3rd state. So I can mention the 3rd state. The 3rd state is Sokoto. Sokoto State. Yeah, they are not here. So this is how, just putting it together. You can see Kebbi State above 100% of estimated, but in 10%, 0% when it has to do with stock out, like logistic management, ensuring redistribution, ensuring that every patient is placed on treatment, not just waiting and say, oh, there's no drug, my logistic officer can, but that active approach. So it's part of it. Absorption rate above 100%, in retirement, best, data used for decision making. So that's how we stayed. So if you look at it, you see how exactly we were able to rank those states. So you can see the ranking. If you look at Kebbi State, when you think about HIV, documented 100%. Child TB target, 12%, 21%, target is 12%. I'm just showing you so that everybody will see it the way it is. Then TPT placement, 100% of eligible. Percentage molecular will have a target of 85%. They did 90%. DRTB enrollment, you can see, covered the enrollment gap. Enrollment rate, of course, is the same thing. PPM contribution, 35% is the target, has 30%. The molecular tests among PPM, because sometimes PPM is overshadowed by what is happening on the national, but looking at molecular test access, they also had 95%. Meanwhile, the target is that. So I'm just showing you, and based on this, and so many other innovation, in fact, for contact tracing, with the fund for contact tracing, they focus on getting TB patients, knowing that the resources for community is not enough. So because in getting TB patients, they focused the community workers and some of these women who can move into a lot of homes to focus on getting TB patients, knowing that if you get a TB patient, you can still contact trace and place on treatment and place on a TPT. Then polio, they had to take advantage of. In fact, before we started talking about integration this much, they were already integrating with MSF, with polio, and getting results. And they can cascade each of those contributions and tell you, this is the number of patients we got from polio, this is the number of patients we got from with our integration with MSF. They've also been the state, I don't talk about testing week, but they've also been the state with the highest exports of true life stories and pictures, showing us that what we are doing in the field is not just the numbers, they are putting up faces. Like this lady, this girl, 13 years, you can see her. Can you imagine this beautiful girl came out from this? So those visualizations that give us the opportunity or gives us the vibe to be able to talk. So when we are saying patients, we are seeing picture of Fatima. And whatever we want to say about that, we are thinking, what of all the Fatimas? No, we shouldn't cut this. We shouldn't do this, which is important. I know so many times we say, send us your stories. A lot of people don't send stories. So like I said, for now, if you see your name, it doesn't mean you've left here from what we have now. You've left here, seriously. And that's why I showed the first one. And I showed that a lot of people have gone up. So don't be discouraged. But allow me to talk. Okay. Amy, every time I take the mic, you cut my time. Why? So, but just to mention that the states we have here, we know what happened, please. So don't classify yourself and don't take pictures, please. They've left here. Okay. So because we know there was a time when they had done worse, and gradually we see them improving, especially when we send them some feedbacks that shows that a lot of their local governments are falling, a lot of their facilities are not reporting. Don't worry, this state has left here, so I'm just showing you. And we go ahead to mention those facilities for you and what you can do within those states. So with these few points of mine, before I will want to call on, you already know the third position. If you're from Northwest, you can receive it for, oh, who is presenting? Okay, I think it's Margaret. Oh, okay, Margaret first position. Oh, no, there will be somebody for third, somebody for second, first. Okay, the minister. Okay. Okay, come and call the person who is presenting. Come and call us. Okay, so I've been given, okay, to present the award, we want to call the STA to the Minister on ATM issues. And that's Dr. YY. Okay, Dr. YY. Put your hands together. So in third position, best performing states. If you don't hear your name in our annual review, don't say I was third here. I wasn't third here, please. Best performing states, all run, including implementation. Sir, please, can you come here? Okay, let me give a good background. Sorry, I'm hurrying, please. I want to put TB background, please. So in third position, if you're from Northwest, you can come in and receive the award for Sokoto State, please. Put your hands together. A new program manager has just lasted a year, but joined this grant and has shown a lot of innovations. And for taking over from the previous best program manager, he filled a very big shoe. We were all wondering how he would fill that shoe, but you can see it today. Okay. So, on behalf of Sokoto, we are
okay. Since it's a collective responsibility, it's representing the zone. I said it's meant for Sokoto State. You are from Kano State. You can collect on their behalf. As they are not here, extend our best regards to them and tell them well done. In fact, well done for your entire zone. Congratulations.
Thank you, sir. Okay. Thank you, sir.
So you can remain. You can remain. Then second position. It's not this my champion that I say you will play. It's stand up for the champion. That's for first position. In fact, when I call him, I know you say, oh, he should be the one. I'm calling Kebbi State. Clap now, please. Wait small, wait small. Stand up for the champion first. Stand up. Stand up.
I don't know when last I danced like this, but that's in the spirit of encouragement. I think the coordinating minister himself would have been excited to the extent that I'm sure if he was here personally, he would dance. This is not just happening at the national level. This is a national program. which most part of the activities are taking place at the subnational. And in this case, based on or from the judgment of who knows best how to do it, they have adjudged that you guys from Kebbi State did extremely well. Others have done good, others have done better, but you have done best. So I congratulate you, and please keep the spirit. You can see that when they projected, although Dr. Obioma was being, she said they are not where today, as of today, they are not where they were. I don't know whether she was just being diplomatic, but please let this be a kind of challenge, a competition. Let it be when next we meet here is going to be the other way around, or you all be at the same level. Once again, I congratulate you, Zamfara State. Can keep it up. Oh, sorry, Kebbi State. It's the same axis. We used to have them all under Sokoto State, so congratulations. Congrats. Music again? Okay. For the champions, please. Okay, people are hungry. Yeah, no problems. Congratulations. Huh?
Thank you so much, sir. Thank you, sir. They say you should say something.
Please, can we sit down? Hello, good evening, everyone. Hello, good evening, everyone. I'm short of words. I'm short of words. And I'm dedicating this award to my able 21 TVLS in Kebbi State, and also my partners that were working together. It's not easy. I'm not alone. I'm just the leader, but I have people working under me. Thank you very much, everyone, and we'll continue to work together.
Thank you so much, Stas. Please stay. When we did the generative, when the minister had that engagement in August, the generative workshop, I facilitated one of the teams, service delivery. And interestingly, he was in my team. I didn't know him from anywhere, but I can tell you he was the most vibrant. So I'm not surprised. Please, another round of applause for him, that he has really done well. Sir, you know, the more you do, the more you are given, the more responsibility. In view of all what we've listed here today that we want to do, what commitment do you want to make? Please. And it's not just for TB, but for ATM. Thank you very much.
Thank you very much. I'm looking at it from the service delivery. That is where we are going to start, because most of these activities start from the service delivery. For us, we want to see from screening level at the facility where TB, HIV, and malaria can be screened together. Thank you.
Another round of applause for him. Thank you. So we call on the NC for HIV. He's here, he's on the way, and is just 2 minutes away. But while he's coming, we'll call on someone from HIV to explain the process as well. Just like we did for TB, we'll do the same for HIV. Over to you, please. Please go and sit down. Please, let's give him a round of applause till he gets to his seat.
Hello, everyone. So standing here today, and I have not introduced myself. So I'm Choma by name. I also work with NASCAP Global Fund in Abuja here. So it's also for me a privilege to stand here in front of this caliber of people from the state, from the nation. Before NC, I want to say something to everyone sitting down here today. You are all winners. Just say yourself you're a winner. I know having worked in the South, I know it's not easy. Some of you are going through security challenges, issues, but keep sorting those issues out on your own. So for me, you get first, second, or third, but you're really a winner. So don't leave me to some things that have happened today. I will from the first person that actually committed, but next year, I assure you, we are going to put a lot of things together to our winner. So, but just for this, we are just going to speaks. Because it is not done. So as we're going back to this, everyone attention to our data because data tells the story. So here we mentioned 11 at 2024 compared to 2025 as well. So if you do 25, it will not show data. So look at those performances across the two. Also look at it as well. So you want to bring this result in implementation. Look at that result as well. Look at our reporting rate, because reporting rate is very important. If you don't look at reporting rate, you need to be sure that you're reporting your data. So reporting rate also says much to the performance as well. So look at all those three. And as well, some of us will be thinking, okay, if I do well here, the calculation, because you use 100% as that not to normalize that the percentage calculation, because if you do well in NSC or skill but didn't do well here, so use that 100% to be able to get the real best state. Look at that and according to the best performing state. So if it's not win today, the next year, if you go back to your state, sit down, strategize, have meeting. When you come back next year, you might be the winner. So also, one good thing about this is that over 26 states scored 70% and above. Appreciate yourself. That is a real lot. So how over 26 states have that 70% and above. It's a real lot of achievements. Also, the lowest state just have 53%. Remember, this proof 53% is also a pass. It may not be A, maybe like C or D. Also pass. So we are doing well. First I say all of you are winners. So standing here today, don't leave here thinking I didn't win today. Just know that you're a winner. And I know by next year, you're going to do well. So that was still much of our time. So let's look at this. So look at the indicators that we used to. We looked at the ANC performance 2024, 2025. We looked at women tested for HIV. Remember, target achievement. So look at our targets and our achievements with it. We also looked at women who are tested for syphilis, 9 months achievement for 2025 because of the data has still been reported. We have not cleared up the enders, so I will use enders for this. Also, have people from NACA. NACA also brought 4 indicators, and those indicators are reporting rate because it's created target, so they use reporting rate from NACA. As well, we also looked at percentage of HIV exposed infant receiving DNA PCR test within 2 months. We also look at ART because it's very important. This is like a cascade of ANC. Women that came, women that tested, referred, children brought from the HIV exposed children that were taking the PCR result, they were taken to the lab for sample analysis and all that. Also look at reporting rates, we see it in our community. Also look at conventional and non-conventional side. What are the good things about unconventional side that they have to report? Whatever they are doing, what they are doing is not done, is not documented. So look at operating rate from our conventional, unconventional, and then comprehensive. Because a lot of attention goes into comprehensive. So we need to look at what our conventional sites and unconventional sites are doing as well to compare. Also look at health facilities to compare. So these are 11. Why is looking a bit buggy is because we're looking at up to 2024, 2025 with the same indicator. But there are 11 indicators total that we use to measure the performance. So we have to wait for the NC to come to present this. To say I must be here to present this award to the performing states. Some of us are looking in my state. Don't worry. Something might be your state. Something might happen. So I think NC is almost here for the award presentation. But just have one thing in mind. As I said, all of you sitting down here, we are all. One good thing, as I said, next year have in mind that we are going to be doing, apart from performance indicator rates, we're going to be looking at other program implementations. Are you able to address challenges? Are you able to be innovations? Are you able to be creativity in all you are doing? So we're going to be putting all these things together in the next year presentation. So when you go back now, state by state, sit down, strategize, prioritize, what you're going to be doing differently. So when you come here next year, sometimes, some 2 years back, we had this kind of presentation across the state where I was coming from. The state that came last that year, they told themselves, no, it will not happen again. After the next year, those states came back and they performed, even though they didn't take first, but they're among the top 3. So one good thing about this presentation is not about my state is not doing well. It also encourages everybody sitting down here that you see what you are doing. We are encouraging you, this kind of incentive to encourage you to be doing well, to be doing more, that your effort will not just go recognized. So just see it as kind of a motivation for the work you are doing. Live here in this hall this afternoon. As you're eating your lunch, just be happy that you're a winner. You are going to, the next year, you are going to do more to make sure that everybody see what they do, both best performing and also poor performing side.
Okay.
Good afternoon again, everyone. I'm just using the opportunity as we are buying time for the NC to come, and he's here now. Excellent. Because I know as soon as the award is given, we are going to walk out. So I wanted to just take the opportunity to say a big thank you to all of you. I have to say we've done this a few times over the years, and I've been really, really impressed by the level of engagement in this particular meeting. I think the presentations, even from day one, many times when we come for these review meetings, NASCAP presentation is always, we leave it with, with a lot of question marks on areas to improve. But I have to say that looking at how NASCAP was able to analyze its data, also NACA, NTB, of course, is always excellent. It really gives us a lot of encouragement at the country team to continue to advocate for Nigeria. As you know, the Global Fund funds over 120 countries all over the world, and it is never a given that countries will get resources, they'll continue to be supported, but you continue to make our work much easier. Because whenever we are trying to explain, okay, this performance may have gone down, but we came for review meetings and we had it was because of A, B, C, D. Context-specific issues that allow us to really continue to advocate for you. So sincerely, the community representatives, you are always a champion. You're always, accurate in your analysis of what the issues are, and you keep us, all of us, accountable, whether it's the funders, whether it's the government, and we don't take that for granted. So I wanted to just pass my sincere thanks on behalf of the entire Global Fund country team, Dr. John Toma, who had to join the malaria meetings, my colleagues who have stayed online throughout the last 2 days, and they'll be with us again for the next week, for those who are here next week. Thank you and all the best and safe travels back to your states. Back to NASCAP, drum roll. Yes.
Okay.
So we're going to be starting with the third position. So the third position for today.
Thank you. So it's been a wonderful session. Yesterday we've been having innovations, new ways of doing business, and for us, I think we appreciate this. So it's now time for us to do the award for the HIV program. And so Shoma will be calling the names, and I will just stand as a statue and just be giving the awards at the plaque out. So I will dance. They didn't tell me that before calling me. So thank you. The states have done wonderfully well. Actually, a lot of states, the improvement over the years. If you look at the data trend, states analysis, national, you see improvements across board. And that's due to the efforts of NACA, NASCAP, IHVN, the SAP, the SASCAPs, and the SACAs. So please, let's clap for all ourselves once again. So thank you. So let me hand over to Chairman now to do the calling.
Thank you, sir. So the third position goes to
Use the system.
Don't mind. Jigawa State! Please, music. Jigawa State, are you there? You're not here. Please, who's collecting for Jigawa?
Kano, just
So this award is presented to Jigawa State for outstanding performance in the implementation of the GC7 grant, presented in recognition of exemplary commitment and impactful contribution to the success of the Global Fund Cycle Round 7 program. Thank you. Please, let's clap for Jigawa State. Thank you. Thank you. Congratulations. Next state.
What is going on? The next state goes to Gombe.
So, Gombe. Let me ask you a question. How did we know it's Gombe? They saw it. Okay, it leaked. Congratulations, Gombe. Gombe is actually my second state, if you don't know. So thank you. Come and hold it for me. So I can shake. Let me send it to you.
So the first position, please, now you all stand first. I call the first position. Stand. Let's stand.
Let's stand up.
Please, anybody to welcome to the podium, the first position for this occasion in this.
Debbie.
You can guess it. The first position goes to Ebonyi State.
For the champion, for the champ. Thank you very Stand up, stand up for the champion, champion. Stand up, stand up, stand up, stand up. Stand up. Thank you, merci beaucoup. Bon après-midi. This award is presented to Ebonyi State for your outstanding performance in the implementation of the Global Fund Cycle 7 grant as the first position, presented in recognition of exemplary commitment and impactful contribution to the success of G7 program and Nigeria as a whole. Thank you, congratulations. Gombe team.
Congratulations.
On the TB and HIV side, please can you come for pictures here? And then, please come. Dr. Mensah, please come. Then, as they are rounding off, please, let's get our materials. We have to take pictures outside, group pictures outside. Kebby is not yet here. Kebby, bring your award. All the people that got award, please come to the front, please. Oh, it remains one, Abi. Eh. Hello, Matuki. Thank you so much. Thank you. Okay. Dr. Basharu, please give. Gombe is missing. Thank you. Please, we are closing. Our boss, Dr. Mensah, will give the last remark. He gave us the opening remarks and is going to give us the last remarks. Okay, so Dr. Mensah gave us the opening remarks, and then we can take the closing remarks from Dr. YY. Dr. YY, the essay to the Minister for Health, will be giving us the closing remarks. Please, let's listen to his closing remarks, then we go out for the pictures. Thank you. Chief, Dr. YY.
Thank you. I know it's been a very long day, to the extent that out of excitement, people are not even in a hurry to go for lunch. Hello? I know that we're in a hurry to go for lunch. That's just the truth. Eh? But then, let's just respect this protocol. There's the need to say thank you to all of you. And I'm going to do this on behalf of the coordinating Minister of Health, with his colleague, the Minister of State for Health, and my dear Permanent Secretary, Federal Minister of Health. There are too many things happening at the same time. Even within town, I can assure you that not less than 3-4 programs that even in my small capacity are meant to be at the malaria rethinking intervention review going on at exclusive Serene Hotel. And that's where I was yesterday. There's a program currently going on, malaria related to at Rockview Royal, which is the other one. We held one earlier at the ministry. The same thing yesterday. Minister himself, Director PhD, DGNACA, are all out of the country, attending a program in South Africa. They were all have been here because of the importance. They all attached to this program. But on their behalf, I just want to, first of all, express our sincere appreciation for the support, in fact, tremendous support the Global Fund are giving to us. You're number one. Others follow. I wish JT was here. He was here this morning. Thank God Margaret is here. Tell her that this is what we said from the Federal Ministry of Health side. The 3 national coordinators, oh, as far as this is concerned, is the 2. My big friend, Dr. Bashorun. Clement was here this morning. I don't know where he ran to, but I don't accuse anybody for leaving one meeting. I'm very sure he's committed somewhere. That's why he had to leave early. My friends, you and I have retired from the service, but you are not retired. I'm talking to you, Dr. Anike. You can see he's our retired Director of Public Health. He's out of the service. He would have been somewhere resting, but we can't just jettison this resourcefulness that you have. You have to be with us, giving us all the technical, moral, and whatever support. Other colleagues here, the IPs, you are so wonderful. My able and very agile and hardworking state representatives in the 2 areas, both HIV and TB, you can see. Dr. Obioma was so diplomatic. And it's not just about diplomacy. I know everybody has put in his very best. So the fact that some people receive awards does not mean really others have not done their best. It's based on certain indicators. If we had extended, bring in other indicators, possibly you would have also gotten up there. But for now, this is what happened. And like I said earlier, we want to see the table turned upside down, or at best, men on the same platform. Everybody must win award when next we meet. Lastly, let me just say thank you very much once again. And while those of you that are traveling outside Abuja, We wish you a very safe trip. May God bless you all.
Amen.
And thank you for all the efforts to make Nigerians live a healthier life. Thank you very much and have a good week.
Thank you very much. Let's give him a very big round of applause. He's been with us since morning. That's dedication, that's commitment, that's ownership. And for those that didn't win an award, let's give ourselves a round of applause for those that are going to be here next time. I heard some people said they need awards for the best participation. So celebrate yourselves here. Let's celebrate ourselves. So right now, just before we step for lunch, yes, we're going to take our pictures, paparazzi time outside, just near the foyer. We go outside and take our pictures, group pictures, so that remember this day, 2025, November 6th to 7th was what? Joint TB review was what? I can't hear you. What did you say? All right, so with that, I'd like to say thank you very much. It's been an amazing time, 2 unbelievable days, great conversations from the online community to the community in the hall and then back to the online. So, and thank you everybody that came from every corner of Nigeria. So with that, we would like to call it a wrap and say, God bless you all. Sure, absolutely. So with that, we'd like to say God bless you all and God bless Nigeria. And what better way to say God bless Nigeria than the pledge? So ladies and gentlemen, can we just kindly have the pledge? That doesn't sound like the pledge. Ngozi, that definitely doesn't sound like the pledge. All right, so we just do just like we did on day one, opening prayers. It's our country, it's our thing. Pledge. I pledge to Nigeria, my country. Amen, and thank you very much. So don't forget pictures just before you step for your lunch. Let's remember this and capture this moment. We're going for pictures outside, please. And thank you, beautiful people. Ngozi, are you there, Ngozi? Please. No. I want to hear beautiful people.